In the last recent 10 years, two major developments for my perception have made it possible that sleep became a topic also in these large ongoing population-based studies, and this is technology and algorithm development. So instead of putting patients or participants into the sleep lab for a whole night, we bring the sleep lab in the form of small wearable devices, multi-channel powered devices to the participant. Also, in parallel, the development of powerful algorithms that can detect sleep characteristics out of smaller and more easier to assess signals has become a major development area. And these two streams, these two developments now make it possible that sleep can be more easily assessed, and sleep became a major topic also in epidemiology. And I'm pretty sure it will go on in the next years because more and more studies detect those small variables that are able to provide results on certain aspects of sleep. And I'm very interested and particularly thankful to the organizers that they brought together a broad spectrum of experts and speakers who address those methods related issues, but also present results from larger cohort studies all across Europe. And I'm really eager to hear what you have to say this morning. And Heike said it already, use the time also in the break or afterwards for networking, exchange of ideas, exchange of procedures. How did you do this in your study and why didn't you do it that way? Because this is how the field emerges and can grow and things become more comparable across studies. And again, welcome to this mini symposium on a very interesting topic, and thank you to the two organizers for bringing it together. And with these wonderful words on the Sunday morning, I'll get back to Heike.
We don't hear you.
Heike, unmute yourself, please.
I got it now. I got it. Right. We will now go on to Andras, who will, as Professor Berger said, introduce us first, particularly for those who are not that familiar with sleep medicine or sleep assessments, who will introduce us to various parameters that you can assess or the methods you use to assess sleep parameters in especially studies or large cohort studies. We do not mean clinical studies, they use a lab. And Dr. Andras Kirai is actually sitting on the other next door. We will go on and go a bit further, but we start with the next doors here. And he's a physician and an epidemiologist here from the Institute of Epidemiology and Social Medicine in Münster. And he has actually for many years spent his focus of research on sleep medicine, I guess, starting with clinical and more methodological research, and is now really into epidemiological cohort study research. And so he will give us now an overview of the assessment of objective sleep parameters. And then, because he's always also doing outcome research, he will present us later on after the break with results from the BiDirect study, which is hosted here. So Andras, thank you for coming, and it's up to you.
Thank you for the nice introduction, Heike, and good morning, everyone. I'll start sharing my screen. Yeah. So I hope you can all hear me and look and see my slides. So yeah, bear in mind, please, that this will, of course, not be a comprehensive review, just a quick tour about the different devices and tools at our disposal to conduct epidemiological studies in the area of sleep. And sorry, a bit of confusion about the title. Actually, I will, because in the flyer it says that the assessment of objective sleep parameters, but actually I will talk about both objective and subjective sleep assessment. Yeah. Okay. So for the subjective sleep parameters, the gold standard is just to perform or conduct a sleep diary. The idea that the subject will around bedtime complete this diary. Even though it's called gold standard, it's actually not standardized. There's a consensus, or there are recommendations, but should be the core questions about the timing and duration of sleep, sleep onset, and when the subject wakes up, then he or she should just estimate the amount of time spent asleep or awake during the night. And there's also usually 1 or 2 questions about the quality of sleep. And you can optionally extend it with napping, caffeine and alcohol intake, sleeping pills, and other factors that might influence sleep. The advantage of this is that it's collected over several days, typically over a week or 2 weeks. And yeah, it's not sleep laboratory data, it's real-time data. And because the subject is supposed to complete this diary right after waking up, it should reduce somewhat the recall bias. But on the downside, it requires some more adherence from the subject. And we should bear in mind that even under these circumstances, the reported sleep duration may substantially deviate from what we objectively measure as a sleep duration. And there are a lot of studies, of course, where they ask about, especially sleep duration is commonly assessed, and they come up with 1 or 2 questions with regard to sleep duration or sleep quality. I would like to talk about the standardized questionnaires. And one of the most commonly used is the Pittsburgh Sleep Quality Index, which is a mixed bag. It has a lot of questions about sleep quality, duration, and other factors like medication, snoring, and other sources of sleep disturbances. And it has also some questions about daytime dysfunction. So yeah, it covers also the insomnia symptoms. But if you are really interested in insomnia, there are dedicated tools to measure that, like the insomnia severity scale. There are some questionnaires to assess sleep apnea. Of course, the reliability is somewhat limited. The 2 mostly known are, probably the mostly known are the Berlin questionnaire and the Stop Bank questionnaire. If you're interested in sleepiness, then probably the most frequently questioned is the Epworth sleepiness scale, which should be actually called drowsiness or somnolence scale, because it asks about your tendency, likeliness to fall asleep in everyday situations. But there are also questionnaires that specifically ask about the subjective feeling of sleepiness, like the Stanford sleepiness scale. And there are also questionnaires about the chronotype. The 2 most commonly known are the morningness, eveningness questionnaire and the Munich chronotype questionnaire. Okay, of course, there are a lot of other standardized questionnaires that are related to sleep, but I will go on because probably these are the most commonly used, and go on with the objective assessment of sleep. The gold standard is, of course, polysomnography, and we measure a lot of things during the night. Of course, EEG and EOG, and also muscle tone, from which we evaluate or score the different sleep stages at every 30 seconds. And as you may imagine, that's a quite time time-consuming process. This is one of the obstacles, I think, in the use of the epidemiologic settings. And yeah, it's quite burdensome. And the subjects should come to a sleep laboratory, although I should say that the ambulatory devices are available for many years, and there are some large studies, epidemiologic studies that use in-home polysomnography with huge success, and like the HypnoLaus study. And it requires special equipment. It's quite expensive, and it also requires, of course, expertise to set up and also to evaluate it. And I think these are the reasons we do not see too many large-scale population-based studies with polysomnography. And okay, what are the other options? Then there's actigraphy, which is around for some 60 years, I think. And as Professor Berger told us, yeah, there's the really new algorithms. So it's the accuracy of detecting sleep and wake cycle has increased a lot. But still, there's the issue, if you just measure activity, there's the issue that if someone lies motionless, awake, then it's really difficult to differentiate that from sleep. So the specificity to detect sleep might be compromised. But of course, you can measure it over an extensive period of time, which is a big advantage. It's also real-life data. It's more accessible, easier to wear. But I must add that research-grade devices are not necessarily so cheap. And yeah, it could be daunting that there's many alternative algorithms out there. So it requires also some expertise in signal processing and in choosing the right algorithm, choosing the right setting and threshold. So how it looks like, here are two examples. The first one here is someone in a care home. And yeah, you can see here the quiet periods, but actually the subject is quite active. So it's moving a lot, probably a lot of times awake. So it looks like a poor sleep. And yeah, the subject is probably also dozing off during the daytime because there are extended periods of motionlessness. And here's another example. Here the subject is, yeah, the night seems quite, the sleep period seems quiet and motionless. An interesting phenomenon here is the social jet lag. So on the weekdays, the person goes earlier to bed and the sleep period is shorter, whereas on the weekends and even on Friday, the sleep period is extended. And this is the one of the advantages of actigraphy, that you can see this pattern, whereas in polysomnography is typically performed in over one night or maybe 2 nights. Okay, so and there are a lot of other options to measure other data besides or in parallel with actigraphy. This is a device, which is the core device is an actigraph. And you can extend it with different modules depending on what you're interested in, like respiratory module, or you can monitor ECG and the pulse oximetry, or if you want to have a more reliable data about sleep, then there is an EEG module. So there are, and of course there are other devices as well where you can combine and be flexible. There is always a trade-off. The more data you require, the more burdensome it will be, the subjects, and probably the more limited will be the time period that you will actually measure. And I think it's worth mentioning one of the things with the actigraphy, if you combine it with the heart rate and the heart rate variability, then the prediction of the sleep sleep awake, and even the different sleep stages will become much higher. So there are many algorithms now out there. So that could be one option if you do not want to go with the EEG, just to combine heart rate variability with the actigraphy data. And I wanted to mention that there are now mobile EEG devices out there. They are mostly used in neurocognitive science or area, or neurodevelopmental diseases. I don't see too many sleep studies, but I think some of these, especially that with less electrodes, I think this should be applicable in sleep studies. So this could be one thing to consider. And as I said, in neurodevelopmental studies, there are out there now large-scale epidemiological studies with EEG recorded with such devices. So I think this is something also interesting. Could be interesting in the sleep research. And just an honorary mention about a lot of different sleep trackers and fitness trackers that also collect data about sleep. The problem with them is actually not targeted for clinical use or for research use. So they do not fall under the same regulations as medical products. And you don't really, and they are not readily validated. And it could be also difficult to validate because most of the times they are black boxes. So you don't know what's happening, what's the algorithm inside. You usually don't have access to the raw data, raw signals. But still, there's an increasing number of validation, and some of these devices actually can work so well as an actigraphy, for example. So I think there's a future in there, but just please bear in mind that you really need to choose carefully and look at the validity if you want to use such a device. There might be some surprises because the manufacturer might, for example, upgrade the software without any notice. So there are some traps there, but I think in the future we will see more and more studies conducted with sleep studies conducted with such devices. Okay, so I think that was my quick review about the potential sleep devices and sleep tools. I don't know, I asked Heike if there is some time for questions, or should we do some session after all the talks with the questions?
It's time. It's time enough for questions after each talk, so we plan enough time. So if there are questions now, I've already got one via chat. Professor Heinze, you want to personally address it, or?
Actually, yeah, we developed based on the HypnoLaus cohort, where we have a lot of polysomnography. We could retrospectively look at the main predictors of sleep apnea, and we built this NOSAS score, so it's a bit a self-promoting remark, but actually we could validate it on our cohort and on different cohorts, and many other cohorts in Asia and other places are using this NOSAS score. I think the stop bang is very easy to use because it's only 1 point per item, but it's positive in 95% of the clinical population. So it's less discriminative than ours, and we have also a very good negative predictive value, which is very useful in clinical setting. So I would just wanted to mention this one. And the Berlin score is not so commonly used now because it's very complicated and the performance is not so well validated. So I just wanted to mention it. Sorry.
Thank you for that. Yeah, I'm aware of that score. I also have a question about it. Then how well does it work with moderate with patients with moderate sleep apnea? Because I think that's one of the problems. It's in the range of around an age apnea hypopneumonics around 15. Many subjects, many patients, especially when I look in a population-based setting, so they do not go to the clinic because of some complaints, do not really snore, they are not necessarily obese. So how well it works in
starting from an HI of 10, so we did the comparison with NOSAS, between NOSAS, Stop Bang and Berlin in different cohorts, and from a threshold of 10 and even more in 15 and 20, then the area under the curve of the ROC curve is higher for NOSAS. But I mean, you may have different results in different cohorts. But also, you could wonder whether an HI below 15 is very significant or not. Yeah. I won't show it today, but when you use such a low threshold, you have 50% of the men above 50 years old who are positive. So it depends what you want to detect. If you want to detect a significant condition or just a very low condition that may not be a pathology by itself. The only problem with NOSAS is that for women, non-obese women, we have sometimes false negative results. We should acknowledge that, but otherwise, I think it works pretty well.
Okay, thank you for that comment.
Professor Berger had another comment.
Sleep apnea is a very good example, and I have a question for both Andras and Raphael. If we take sleep apnea as an example, from your both experience, what would you recommend what type of question can be solved, can be addressed by using such a questionnaire? And what is the type of question or problem to analyze where you would definitely recommend either one of those devices or a polysomnography in a sleep lab? So just to differentiate the use of questionnaires in population-based research is still common, or what are the edges? What is the border where you say, okay, this is something, given your resources, you can use a questionnaire such as the one you mentioned, or this is definitely a research question where you have to apply devices or a sleep lab. Tricky question, I know, but that's where the experts here.
Well, if I can start, the NOSAS questionnaire, for example, is good for screening. It has a strong negative predictive value. So in clinical setting, in clinical research, we could use it first to exclude negative subjects. So because we have a 95% negative predictive value for an HI of 20, and then do clinical investigation such as polygraphy or polysomnography in those who are positive. If we want to do this two-steps approach, that's how it was conceived. But otherwise, of course, each questionnaire, for example, the Stop Bang questionnaire will be highly inclusive, but not very specific. Depends exactly how you want, if you want to have to detect everyone or just to be more specific. So each questionnaire has its specificities, I believe.
All right, thank you.
Thank you, Andras, for this nice overview, and thank you all for opening up the discussion, because that's why we're here. We want to discuss, and we actually have plenty of time to discuss after each talk and at the break time. Okay, so I guess we will hear about some of the methodological points or assessments in each talk. And first of all, now we will introduce Dr. Kantelhardt. He will go on with methodological as well as a few outcome findings, I guess. And Dr. Kantelhardt is a computational and statistical physicist working as a research fellow at the Institute of Physics of the Martin-Luther-Universität, Halle, Germany. His research focuses on interdisciplinary applications, mainly in medical time series analysis, which we have here, And he has developed and further advanced methods from statistical physics to study scaling behavior and interactions between several kinds of medical time series. So, for example, he closely collaborated with the mainly epidemiologists from the German national cohort and prepared the sleep recordings in this study. And he is still supervising the sleep recordings. So as I can see now, there are already 17,000 subjects with sleep recordings in the German national cohort. And Dr. Kantelhardt, as a current vice head of the German national cohort expert group on sleep research, will now present methods and findings of this huge cohort. I'm very excited.
To present methodology from the German national cohort here in this very nice symposium. Yes, I'm focusing on these data from the German national cohort, and as you see in the number of subjects, it is not possible to use the gold standard polysomnography for all of them. But also, we are not just relying on the questionnaires, but we want to have real recordings and also recordings with multiple channels. It is not just accelerometry, but also heart rate and respiration. And so I will go a bit into methodology issues in the first part of my presentation, and then I will also show some preliminary results. As a motivation, well, I think to most of you, it is clear why we want to do sleep assessment. It is because problems with sleep or sleep apnea lead to general risks in the population, increased morbidity, mortality, and so on. The gold standard polysomnography, as Andras had told, but I will focus on these accelerometer devices that record acceleration on 3 axes. So we have this coordinate system linked with the device that is worn as a watch, like a watch on the wrist. But the device also has a cable attached to it, and this cable is going to 3 ECG electrodes. So we simultaneously record an ECG, and it is also connected to a tube that goes to the nose so that we can record nasal pressure or flow. How do these recordings look like? This is just an example, 1-minute data recorded during sleep at 6 a.m. in the morning from just random subject here. And you can see the recording of the ECG, respiratory flow, and also the 3-axis accelerometry. While the subject is in quiet sleep, accelerometry does not seem to show anything, but we will look in more detail in a minute. And then we can see that also during quiet sleep, accelerometry shows something. But of course, large things occur when there's a change of position, when the subject is moving from the left to the right side or whatever. And often these changes of position are also associated with interruption in breathing and some disturbance in the ECG. So here, ECG may not be so reliable just because of this movement artifacts. It is good to have multi-channel data, because then we can use these multi-channels to check each other, so to say. How does that work? Well, at least during the quiet sleep, we can use the accelerometry data to also see respiratory activity. So we have 2 ways of accessing respiratory activity. One is the respiratory flow, but sometimes the sensor at the nose falls off or is not really recording anything, is unreliable. Then still we can see respiratory activity because it affects the acceleration at the wrist. The respiratory cycle leads to a slight turning of the wrist. I'm exaggerating very much now, but it is a very tiny turning angle only. And here the axis is in milli-G. That means 1/1000 of the gravity acceleration. So it is very tiny oscillation here. And it also kind of buried in the noise here. But if we smooth the signal, we can still see very well this, this acceleration oscillation here, which is due to the respiratory activity. And this can be used to derive respiratory activity just from wrist acceleration. And as we showed in these papers, these two papers, this derivation of respiratory activity from the acceleration is much more reliable than the way other studies often derive respiratory activity by looking at the ECG and looking how the QRS complex height oscillates, or the maximum of the QRS complex, or the length of the R intervals. They oscillate via respiratory sinus arrhythmia. And if you want to use those for getting a proxy, a reconstruction of respiration, it is much less reliable than these signals obtained from acceleration. The acceleration signals can also be used to derive heart rate and even individual heartbeats. And this is shown here. Here we have the slow oscillation, hardly visible, but still maybe you can guess. The slow oscillation is due to respiratory activity. These spikes here, they are due to the heartbeat, because the pulse wave goes through the arm and passes through this wrist accelerometer, and it leads to a slight impulse here each time the pulse wave goes through the wrist accelerometer, passes the wrist accelerometer. With some signal processing, this way we can derive the pulse wave, so we get a proxy, a reconstruction of heartbeat activity, even if the ECG fails in some recordings. But if we have both, we can also calculate pulse transit time from that. That is the time from the occurrence of the R peak in the ECG to the time the pulse wave arrives at the wrist. So we have another signal derived from that, from this combination of ECG and acceleration, and that is pulse transit time. And as you can see here, the pulse wave intervals and the RR intervals are very, very similar, at least when the acceleration measurement is not disturbed, when there is no change in position, when the subject is lying at rest, like most of the time during sleep. This works quite well. And therefore we can reconstruct the pulse wave and the heartbeat very well during most of the sleep stages. It is a bit worse during wakefulness and during the night, just because there's more motion activity and there's more disturbance in the acceleration recordings. Okay, now the next point is, how can we obtain information about sleep-wake transitions from the accelerometer data? This plot looks quite complicated, but actually what am I doing? I'm calculating power spectra of the wrist accelerometer data for all three axes, X, Y, and Z. And for the beginning of recording, then we have sleep onset about here. And then we have the night, and you can see during the night, there's much less motion activity as characterized by the blue or green color compared with the red color that shows high motion activity. And since these are power spectra, here we have certain frequencies. For example, you can pick up the respiration frequency here, which shows up as a red line just because you have a peak in the power spectrum, and you can follow the respiratory frequency. If it is 0.3 Hertz corresponding to 8 breaths per minute, or if faster, you can follow that. And you can also see, well, the device records respiratory activity all throughout these sleep periods. If the subject has disturbed sleep, for example, in this case, where there are a lot of apneas, 87 per hour, apneas per hour. Here there's just 2.9 apneas per hour. In this subject, you can see there's a lot more motion activity, not just in the respiratory band around the 0.3 hertz or in the heartbeat or pulse wave band, but also in many other frequencies are involved because the subject has a lot of other motions due to reaction on the disturbed sleep. So you can see that already from brief looking at these two spectrograms that they can be used to assess disturbed sleep. And they can be used to distinguish sleeping periods from periods of wakefulness, like the one that occurred here 6 hours after 10 p.m. So that is 4 a.m. in the morning, a typical wakefulness episode during the actual sleep period. In order to extract the difference between wakefulness and sleep more thoroughly, I have now plotted the power spectrum here for each of the 3 types of activity. 4 types of activity, also daytime activity. During daytime activity, there is quite strong motion activity for all kinds of frequencies, 1 hertz, 1 hertz, 10 hertz, and so on. When it comes down to nocturnal wakefulness, well, the total power spectrum goes down, but the slope of this in the double logarithmic presentation is still close to minus 1.5. When we go into real sleep, which could be deep sleep, the dark blue curve, light sleep, the light blue curve, or REM sleep, the orange curve, you can see that the baseline here has a much lower slope of just minus 0.4 approximately. So the change in this scaling behavior can also indicate if we are in wakefulness or in sleep. And this is a second parameter that can be used in addition to the absolute height of motion activity. Usually people just look at absolute value of motion activity. So if the subject is moving a lot or only moving very little. But if you compare motion activity on long time scales and short time scales, low frequencies and high frequencies, we get this slope. And the slope is also characteristic of the type of sleep or wakefulness. So we can use this information to distinguish wake and sleep. And that's what we did in this publication that comes from the pretest of the NARCO, where we developed an algorithm that can extract the information of wakefulness or sleep from these accelerometry recordings. Details described in that paper. I don't have time to go to explain them now. If I apply this algorithm to data from NARCO or from other accelerometer recordings, you can see here we identify the sleep period shown in magenta as compared to wakefulness. We also find some sleep during daytime that can occur in some subjects. Yes, it may be also that is this kind of non-weird time. So we have to make sure that we do not falsely classify non-weird time as sleep. But if we have this, we can extract sleep parameters. SomnoWatch only has 1 night recording for each subject. In the NARCO, we also have actigraph worn at the hip, and that has 7-day accelerometry recording. That can also be used to extract sleeping period with the same algorithm, slightly adjusted parameters, but the same algorithm basically as the one applied to SomnoWatch, because this algorithm uses only the accelerometer data. From these sleep-wake distinguish characteristics, done at a time resolution of 30 seconds, just like those for polysomnography. We, for the narco, we have defined a number of parameters and calculated them already for all these 17,000 recordings that are available from SomnoWatch in the first round. Here I will focus just on two of them. One is the chronotype, which is the average of sleep onset time and sleep end time. So if we look at the typical recording here, we have sleep onset maybe here, and we have sleep ending about here, and the average of these two times is the chronotype. The second parameter I will focus on is total sleep time, which is clear, the total duration of the sleep episode. We also have sleep efficiency, wakefulness after sleep onset, number of awakenings, and information about sleep during the day, but I will focus on these two parameters. The SomnoWatch was born in about 17,000 recordings in the narco, with this age distribution, and this distribution as shown here about among men and women. The response rate, if you consider the whole narco population, is a bit below 10%. If you look just at those that were level 2 in the narco, we have about 30%, not much difference between men and women. And the data quality check shows that real time is okay in about 94% of all subjects. ECG is okay in 90% of the subjects. Respiration just about 75%. So the reconstruction of respiration can really help there. Sleep parameters can be determined for 85% of the subjects approximately. Now looking at the results of these sleep parameters, here we have total sleep time. It's a nice Gaussian distribution with a center around 7 hours, just as expected. Typical sleep time is 7 hours, but there are some subjects sleeping much less. There are others sleeping much longer. Chronotype is about 3 a.m. The average of going to bed, sleeping, beginning of sleep and ending of sleep is about 3 a.m. Also with an approximately Gaussian distribution. As expected, this is from a previous publication where you can see that these chronotype values, well, they are expected to have a Gaussian shape with a bit broader tail towards the early morning hours. So the very large chronotypes, they are a bit more frequent than the very early chronotypes. The owls have a bit broader tail than the larks, so to say. Okay, still focusing on these two parameters, total sleep time and chronotype. Here I have plotted them versus the age of the subjects, grouping 3 years of age here. And you can see that usually women sleep a bit longer than men, which is consistent over all age groups. The chronotype of men is a bit later than the chronotype of women. So women go to bed a bit earlier, but this distinction seems to vanish with increasing age. And also the chronotype seems to move to earlier hours, move by about 1 hour if we go from 20 years of age towards 40 years of age, and then it stays approximately constant. So this is the age dependence of sleep time, sleep duration, and chronotype. Similar plot now versus body mass index. Body mass index, we do not yet have the fully reliable information. We just have this information preliminarily for the quality control. So a body mass index is available for about 80% of our subjects. Still, it can be used to check how total sleep duration depends on body mass index. Well, weak dependence, maybe slightly decaying here for men with high body mass index, maybe because they have apneas much more frequent. Chronotype also slightly moving earlier with increasing body mass index. and surprisingly, difference between men and women disappear with increasing body mass index. Yeah, we can also use this data to look at differences between seasons. Well, there are some Somnowatch recordings in winter, some in summer, and so on. They are all from different subjects. We do not yet have recordings from the same subject during different seasons. I'm just about to get them for quality assurance purposes because they are just transferring now data from 16,000 more recordings to the hard disk and about to send them to ship them. So that maybe I will have tool recordings from the same subject soon, but here we have only one recording from each subject, and they are taken on different days of the week and during different seasons. The season effect is quite weak. We have a bit shorter sleeping time during the summer, slightly longer during the winter, but chronotype is not affected by the season, basically not affected. We see a very strong effect of weekdays versus weekend. 5 here means recording starting on a Friday. So this is the night from Friday to Saturday. And this is the night from Saturday to Sunday. There we have much longer sleep time and much later chronotype. As expected, but still we can quantify the difference here in the average over many subjects, yes, but also have the individual values, of course. Now I can also correlate this with the position of the narco center where the recording was taken. There are some centers in the east of Germany and others much further to the west of Germany. In the east, the sun goes down earlier and it goes up earlier. Does that influence chronotype? Yes, it does. Chronotype is earlier in the east of Germany and a bit later in the west of Germany. And here I put the line, which is not a fit. It is just the expected behavior because the shift of sun going down and going up, the shift of sunlight period. But this result for total sleep time is surprising. Total sleep time is a bit longer in the east than in the west. Well, in the east, they go to bed a bit earlier because sun goes down earlier. Okay, but they wake up similarly. So this total sleep time in the east seems a bit longer than in the west. There are clear correlations here for both of these signals. And if I subtract the trend line from the sun, then I get a correlation with the size of the city. So in the large cities, chronotype is a bit later. In the smaller cities, chronotype is a bit earlier. This is not shown. Finally, this is the last before my summary. Can we see an effect of time change? So the change of the clock from summertime to wintertime. How does that affect? Well, in that case, I have to look at recordings for each calendar date. And there are not so many. There are about 60 recordings for each calendar date, of course, from different subjects. So this is now at the border of what these 17,000 recordings can show. But if you look at total sleep time, we can see that in the night of the actual time change, here, the sleep time in autumn, where the night is longer, you have quite long sleep time. You have much shorter sleep time in the week following the time change. So this is the night from Saturday to Sunday, where the night is 1 hour longer in autumn, 1 hour shorter in spring. The most drastic effect occurs 1 week after the change of the clock time. But you can also see an effect of chronotype, which occurs here, of course, in the night when the clock is changed. Chronotype is much later in autumn because the night is longer. People are anticipating the change of clock and therefore going to bed much later. They are still going to bed much later in the next week, even though there's no change in clock time. Well, this is not really fully significant, and the error bars are large, as you can see, but this is about the borderline what we can do with these 17,000 recordings. To summarize, I have shown that measurements of 24-hour wrist acceleration, ECG, and respiratory activity are available in this large subsample of the German national cohort. Sleep parameters are extracted by spectral analysis, and the respiratory activity and pulse wave can also be reconstructed from accelerometry. Future aims, of course, an epidemiological analysis of these sleep parameters. This is going to be done by Professor Stang from Essen. He's just waiting for the final data from the German national cohort. We want to develop an automatic algorithm for detection of respiratory problems and sleep disturbances. We're working on a program to calculate cardiac fitness from heart rate recovery. That's another ongoing project with this narco data. And finally, we would like to apply our sleep analysis also to the 7-day actigraphy data that is available for many more subjects in the narco. Thank you very much for your attention.
Thank you so much, Dr. Kantelhardt, for this very, very informative talk and very interesting findings. I'm just trying to put myself in which time of chronotype I am, whether I'm better up in the east or west. Are there any questions? I guess there are a lot. Yes, Professor Heinze.
Yeah, congratulations. It's just amazing, the data that you could collect and what you can extract from it. It's just great. Congratulations. Just maybe I missed it in the beginning. Which kind of other subjective parameters do you have? I don't remember which questionnaires you have about the health in general of these people, to see if you can put in perspective the quality of sleep, the time, the chronotype with complaints of sleep disturbances, daytime vigilance, and maybe cardiovascular disease. Can you just remind me what other parameters you can put in perspective with these ones?
There are very many questionnaires regarding all kinds of other disease, cardiac disease, and all these. There is very extensive data recorded in the NARCO for that. For example, you also have an ergometer test and all kinds of questionnaire data on that. There is a brief questionnaire regarding sleep, but this is much shorter than, for example, Pittsburgh Sleep Quality Index. Although it is just about 8 questions, and they are answered on a touchscreen panel by the people coming to the Narco Study Center. There's information about chronotype and sleep disturbances and so on, and that is available for the full Narco, the 200,000 subjects, but it is not as extensive as these standard questionnaires, and it still has to be put in relation to the objective measurements from SomnoWatch. That has not been done.
Mm-hmm. And do you have any prospective follow-up in some of the?
Yes, there's follow-up in the NARCO. The second period of the second 5 years have started. So about 1/3 of the subjects has already been to the NARCO center the second time. And all of them, nearly all of them, are going to come back for the second time. And currently there is application going on for the third funding period. So there should be longer follow-up for very many subjects.
Any pulse oximetry data on your watch, on the watch? Pulse oximeter?
No, this is not recorded. This is a disadvantage. I fully agree. It would be very nice to have oxygen saturation, but this is not recorded by the device.
Excellent, congratulations.
Professor Berger?
Maybe in addition, those sleep questions that have been answered on the touchscreen by everyone, these include some questions from the PSQI So several of the 7 components that are assessed by the Pittsburgh Index are fully available from all the 200, or those who answered all the touchscreen items. So it's not the complete PSQI because of time constraints, length, and fighting on who gets what instrument in, but at least we managed to bring in the sleep quality component, the length, sleep length component of the PSQI, and one more. So these 8 questions basically all come from the PSQI. And there is no oxygen, but there is a spirometry and a FeNO measurement for those who got the intensive examination program, which is about 56,000.
Wow.
And so you have an overlap of those with the sleep characteristics that were introduced by Jan and those with the spirometry and FeNO measurements. And there is ultrasound of the heart. There is whole body MRI for 30,000. So a lot of stuff that potentially, no, not only potentially, but is interesting if you analyze it in relation with those sleep characteristics. I have one final question for you. So I've heard you presenting some aspects of that, what you have been doing a couple of times in the past. And each time I'm sort of surprised and fascinated what is possible. When we planned NARCO 10 years ago, have never thought of. And so from the SomnoWatch and actigraphy assessments in NARCO, and given your expertise in algorithm development, what do you see as the bigger, larger endpoints still coming up in the next maybe 5 years with some more development in algorithm that would be possible to analyze or to get as an endpoint we have never thought of?
Well, I think we can also get some information about sleep stages, in particular differences between non-REM and REM sleep for the SomnoWatch data. Wow. Actually, co-workers of mine in Israel, Ronnie Bartsch and Yaopeng Ma, is also listening, they have developed a neural network approach and analyzed SomnoWatch data. However, they are not yet able to get any data from the NARCO because this data cannot be transferred to a place out of Europe currently. So they cannot apply this to the NARCO data for reasons of contract issues. But their algorithm is ready. And it will yield not as reliable information as you will have from polysomnography, but still some accuracy of about 65–70% regarding classification of REM, non-REM sleep. And this is ready for the SomnoWatch recordings, waiting for to be applied. But not yet. We have tried that for actigraphy. So application to actigraphy is still in progress.
Okay, thank you.
Thank you. So thank you again, Dr. Kantelhardt, for this really, really interesting talk. Thanks so much for joining us. So we will move on to Professor Heinze. Professor Heinze is the director of the Center for Investigation and Research in Sleep and associate professor at the University of Lausanne. So we finally moved countries. His main research interests are sleep, disordered breathing, sleep in extreme conditions, which I personally find extremely interesting, but I guess the topic is it's not the topic of the day. So extreme conditions meaning high altitude, solo sailors. This is really interesting. But he's also interested in the epidemiology of sleep disorders through the HypnoLaus sleep cohort study. So this is his topic today. It's a population-based cohort study and one of the largest of the field, including also I guess maybe a bit more in detail as the GNC sleep, metabolic, cardiovascular, and genetic characteristics of more than 2,000 individuals. So there are many large cohorts in Europe, and I'm happy to have you here, Professor Heinze, and it's up to you.
Well, thank you very much for the introduction. Actually, it's not so large compared to what you're doing in Germany, and congratulations again for the big work that you're doing. So yeah, I'm going to focus today about the predictors and biomarkers of sleep apnea related risk of cardiovascular disease, mainly in cerebrovascular disease. So these are my relationship with commercial entities, but I think it has no impact directly on what I'm going to say today. And you probably all know about sleep apnea, but I always like to show exactly what it represents. So you have here a short video of someone having sleep apnea, has a sleep recording, and you see that the person is snoring and suddenly stops breathing. So there is the person tries to breathe, but you can see the effort at the thoracic level, but there is no more sound because there is an obstruction at the upper airway level, which prevents the air from going down to the lungs. And then this person has to wake up to open the upper airway again, to normalize the oxygen level. But when this person goes back to sleep, there is again a decrease in the muscle activity at the upper airway level, which makes a complete obstruction of the upper airway. And slowly the oxygen goes down, the carbon dioxide go up, and this stimulates the breathing center at the brainstem, which promotes respiratory effort, but the respiratory effort are worthless because the air cannot come in because of an obstruction at the upper airway level. Okay, again, the person has to get out of sleep to breathe again. So you all know about that, but I think it's important to keep in mind what it really represents in real life. And we make the distinction between hypopnea, when we just have a decrease in the amplitude of breathing, and complete apnea, where there is a complete cessation. Until now, we all estimate the severity of sleep apnea just by counting the number of respiratory events. So it's a very basic way of assessing the severity of sleep apnea. And this comes from the paper and pen recorders era that I still knew about 25 years ago when I was working in the US. We still had these 3 kilos of paper for each night. And this was a problem because all we could do is just count the event by hand. And that's why we had this apnea-hypopnea index, which is merely just the number of events per hour. But now we have digital recorders and we could do much better, but we don't. We have probably hundreds of parameters that we could take into account on a polysomnography, but we just take one magic number, which is this apnea-hypopnea index. So the first question we were asking is whether this AHI, apnea-hypopnea index, is a reliable biomarker. And I just show you 2 examples. This is a recording with someone who has hypopnea. So you see a decrease in the breathing flow here, but no complete cessation, but they are quite frequent because they are short. So you can have several of these breathing decrease per hour. So this person has an AHI of 52, which is very severe. If we look at this other recording, you have very long complete apnea, which lasts for more than 1 minute, with a very important consequence on oxygen level. You see at the bottom that the oxygen level goes down to 52%, which is barely compatible with life. But this person has an AHI of 22. So this person is officially milder than this one, which is from a physiological point of view, probably not true. So this is, I think, one of the main problems of the way we assess obstructive sleep apnea severity and the way we decide to treat or not people. Apnea-hypopnea index, so this is the main parameter that we currently use, is highly dependent on the hypopnea definition. the American Academy of Sleep Medicine regularly changes the definition of hypopnea according to the magnitude of the drop or the association with EEG awakenings or with oxygen desaturation. And when you change a little bit the definition, you change a lot the number of events that you will find, and so the severity of sleep apnea in the same person. Then the type of recorder, whether you add the EEG or not, it changes also a lot this AHI, because if you divide the number of events by the total recording time, what you have to do when you don't have the EEG to determine when the person is sleeping or not, then you have a much lower AHI than when you divide the number of events just by the number of hours of sleep, which is always obviously lower than the number of hours of recording. Then the type of sensor is also very important. If you take the nasal pressure, it's highly sensitive. If you take the thermistor, like in the old studies, it's less sensitive and you see less respiratory event, which has an impact on the AHI. And the human factor is obviously very important, because when you have to determine whether it's 30% decrease or not, two people may have the different opinion. So the question is, are there better predictors than the AHI of sleep apnea-associated cerebral and cardiovascular risk? So in order to answer this question, I will show you some data from the HypnoLaus cohort. It's a population-based cohort from Lausanne, Switzerland. So it's a nested cohort of a larger cohort cohort in which more than 5,000 participants had a full clinical workup. They also answered various sleep questionnaires regarding their sleep habits and potential sleep disorders. So we already talked about the Pittsburgh Sleep Quality Index, the Epworth Sleepiness Scale, Orn-Osberg for the chronotype, Berlin questionnaire for sleep apnea, restless leg syndrome. So the 4 cardinal questions to define restless leg syndrome, the Munich parasomnia questionnaire, which is interesting because not so many cohorts have used this parasomnia questionnaire. Because it's a population-based cohort, it's interesting to determine the prevalence of this parasomnia. Then we had 4,000 subjects who had a head-to-head psychiatric evaluation. This is the HypnoLaus study, and 2,000 of them, aged between 40 and 85 years old, who had a full polysomnography at home, and this is the HypnoLaus sub-cohort. So we have to remember that it's not young people, it's middle to old age people. And so they had the standard polysomnography parameters with the EEG and all the breathing parameters and the ECG. And they were coming to our lab in late afternoon to be equipped with all the sensors, and then they would return home like this woman with the recorder here, you see, with the public transportation, and some people looking at her a bit weirdly because they think she must be very sick to have all these wires on her. And so we recorded these 2,000 people. Mean age is 58 years old, half males, half females, with a body mass index that are slightly overweight, with a BMI of 26, which is lower than many US cohorts, for example. And the Epworth score is more or less what we expect from a general population, 6.2, which corresponds to the Princaps article by Johns in the 80s, I think. And then the next circumference was about 37 centimeters. So we had the first evaluation between 2009 and 2013, and then there was a follow-up between 2015 and 2017 with an average of 4.2 years between these two assessments. So the first one had PSG, and the second one, we had mainly an adjudication of each cardiovascular event. I think this is very important, because if you just rely on self-reported events, or if you rely on insurance data, it's not so precise. So here, each chart was reviewed by a panel of experts, so to make sure exactly which type of event it is and to classify it properly. We also have the cognitive decline. I won't be able to show you the data today, unfortunately, but it's very interesting to see the difference in 4 years in this cohort. So first, the predictors of cerebral and cardiovascular events. So it's a composite outcome in HypnoLaus at 4.2 years. So we first took some of the PSG parameters and some questionnaires. Model 1 was adjusting for age, sex, body mass index, smoking, alcohol consumption, hyperlipidemia, and diabetes. And model 2 was additionally adjusted for sleep apnea and hypertension. So if we take sleep efficiency, for example, we see that it was not significantly associated with the outcome. The AHI was only associated in the first model, but not when we additionally adjusted for hypertension. The oxygen desaturation index, so just the number of oxygen drops, is not significantly associated in the second model. Arousal index, surprisingly, was not. So the microarousal index was not associated. Periodic leg movement, neither. But the subjective sleep quality, Pittsburgh Sleep Quality Index, is, and this is very interesting, even in the fully adjusted model, if you take the sleep quality, subjective sleep quality, it's associated with the incidence of cardiovascular event with a hazard ratio of 2, which is not bad. And the sleepiness was not, apparently. If we take a Cox model adjusted for main confounders, and you just dichotomize the population with an apnea-hypopnea index above 15 and below 15, you see that there is a trend, but the difference is not quite significant. If you take the PSQI, the Pittsburgh Sleep Quality Index, there is indeed a difference in the incidence of this composite cardiovascular outcome. So it's increased in people who report poor sleep quality. Then we also performed spectral analysis of the EEG. So this is a fast Fourier transform, not of the heart rate, as it was shown before, but really of the EEG brain activity central to a C3 electrode that was taken into account. And we divided it into the standard EEG waves like delta, the slow wave between 0.5 and 4 hertz, theta, alpha, sigma, the spindles, and beta, which is highly fast activity. And you can see more or less here on the left that the sleep cycles with the in red, the delta activity that builds up during deep sleep. So we first focused on the delta power, and you see that we divided our population into quartiles, and you have on the y-axis the adjusted cumulative hazard ratio of cardiovascular disease, incident cardiovascular disease, and the adjustment on the bottom. And what you see here is that the people with the lowest amount of delta power were at increased risk of incident cardiovascular disease compared with the fourth quartile, for example. So there is a clear distinction of these people who have a low amount of deep sleep, even if you control for the main confounding. We also test the impact of the sleep structure, macro sleep structure and micro sleep structure on the incidence of hypertension. And this is interesting. So we have just the standard way of looking at sleep, like stage N1, N2, N3, and REM. And here you have the crude relationship with incident hypertension, model 1 and model 2. So these are basically the same models as I showed before. And we see that the human-based sleep scoring was a little bit associated in crude association, but not in the models. So not very interesting. When we take the micro architecture, so the spectral analysis of the EEG, we see that, again, delta power is associated with the incidence of hypertension. So if you have a higher delta power, it's protective from developing hypertension in the next 4 years. We'll soon have the 10 years follow-up, which will be even more interesting. So we're starting analyzing now the 10 years follow-up, but this is for the 4 years. And if we take the sigma power, so the spindle activity, also we find it significantly protective from incident hypertension, even in the fully adjusted model. So then we focused obviously on spindle activity, which is characterized of the N2 sleep stage. And here again, the density of spindles, so the number of spindles per hour, were also protective from the incidence of hypertension, and the power spectrum of these spindles. So the higher power density of the spindles in the sigma power was also protective. And this is also a positive result even in the fully adjusted model. When we take, again, the incidence of hypertension, we divide it into quartiles, we see the same. So the one with the lowest amount of delta power and the lowest amount of sigma power were significantly at higher risk for hypertension compared with the fourth quartile. Then we looked at the hypoxic variables. So we already saw the 3% oxygen desaturation index, but the mean saturation was significant only for the model 1. So the higher the mean saturation, the lower the risk of incident cardiovascular disease, but it was not significant in the fully adjusted model. The time with the saturation, oxygen saturation below 90 was significant even in the fully adjusted model. And the hypoxic burden, which was shown to be associated with mortality in 2 different cohorts, was not significant in ours in the fully adjusted model. So for those who are not familiar with the hypoxic burden, it's the area above the curve of the oxygen desaturation. So instead of just counting the event, you have the oxygen depth, if you want, or the magnitude really of the oxygen desaturation that can be assessed by measuring this gray area above the oxygen level curve. So if we take the quartiles for the hypoxic burden, again, we don't find anything in our cohort. I think other cohorts also from Australia, I didn't find anything with the hypoxic burden, but the sleep heart health study in the US found something about mortality. Interestingly, we have also 700, almost 800 who had a magnetic MRI of their brain. And my colleague Nicolas Marchi was looking at the volume of different structure in the brain. And he really saw that on the left, all the hypoxic variables, especially the mean oxygen saturation, the hypoxic load, which is close to the hypoxic burden, and the T90, the time spent with a saturation below 90%, were associated with a decrease in the volume of the temporal lobe, and especially the hippocampus. And this is interesting because these are structure, I'm not an expert in that, but that are related with memory. And we know that, that there is a cognitive decline in people with obstructive sleep apnea, for example. And so now we are looking at the evolution of the cognitive and psychometric parameters that we have in the prospective follow-up to determine really what matters to define, to predict the decline in cognitive function. And I can already tell you that the hypoxic parameters seem to be the main predictive factors. That's why I was asking Jan about the oxygen saturation. And this was recently published in the Annals of Neurology. Then we also focused on what we call autonomic arousal. So autonomic arousal represents autonomic reactivation during sleep. And this can be assessed through the pulse wave amplitude that can be measured by the pulse oximeter. So the pulse oximeter emits red light and has a sensor to determine the attenuation of this red infrared light on the other side of the finger. And you see the signal here on the bottom of this attenuation. And when you have a lower amount of blood in the finger, when you have a vasoconstriction following an activation of the sympathetic nervous activity, you have a decrease in this signal. You see this drop in the amplitude. So this represents an activation of the sympathetic nervous tone following an arousal, for example, and a reaction of the endothelium of your finger vessels to generate this vasoconstriction. So we were interested in the duration and especially in the number of this reaction of more than 30%. You see here a recording with each time you have an apnea, for example, you have a decrease in the amplitude of the signal, but you also have spontaneous variation. Each time you have a small noise, each time you move your leg, you will have that. And people who have a highly reactive autonomic nervous system and people who have highly reactive endothelium to generate vasoconstriction will have a lot of these variations. So this, you can see that it's quite normally distributed signal, which is always nice to see that the duration and the number per hour of this decrease in pulse wave amplitude. And so we divided the frequency of these events into quartiles. And you see that those who have a high number of these variations, so people who have highly reactive autonomic nervous system and blood vessels, have a lower hazard ratio for developing cardiovascular disease. And those with low variation, so have unresponsive autonomic nervous system and unresponsive vessels, have a higher risk of incident cardiovascular disease. And this is the 4.2 years follow-up, and we soon can analyze the 10 years follow-up. So we also try to focus on people with sleep apnea. And so if you take, because one of the main questions is who we should treat among people with sleep apnea, because many people have sleep apnea, but we cannot treat everyone. So we would like to know who is at higher risk for incident cardiovascular disease. And so we take people with an AHI above 15, which is considered moderate to severe sleep apnea, and low pulse-wave amplitude variation, so a low number of this drop. So these people are at much higher risk to have incident cardiovascular disease compared with other people who have also an AHI above 15, but high variation, so highly responsive autonomic nervous system. They are at lower risk, as low as the people who have no sleep apnea or low sleep apnea. And then we say, okay, this is nice, but maybe we should try to reproduce that in another cohort. So this is another cohort, a cardiovascular cohort and sleep apnea with a follow-up, also prospective follow-up. And you see again, those with an AHI above 15 and low pulse-wave amplitude variation are at high risk for recurrence of cardiovascular disease compared with those with an AHI above 15 and a high variation. And I won't show it today, but those with a low pulse amplitude variation tend to respond to the treatment, to CPAP treatment for sleep apnea much better than the others, because there is definitely room for improvement. So now we're going into physiological studies to better understand what it means and what are the main determinants of these pulse wave amplitude variations. So just to conclude, so AHI is probably not the best predictor of incident cerebral and cardiovascular events. Other interesting candidates could be nocturnal hypoxemia, objective sleep clarity, especially the spectral analysis, the microstructure of the brain, which is more objective way to look at sleep more than just the N2, N1, N3 stages. Subjective sleep quality could be an interesting parameter. The way people feel about their sleep could be also interesting. And the pulse amplitude variations could also be the reflect of impaired endothelial or maybe impaired autonomic nervous system adaptability, which has been shown individually to be risk factors. So the open question is whether there are different biomarkers for different outcomes, maybe cerebrovascular disease and cardiovascular disease and depression and sleepiness may have different predictors because there may be different pathways that connect sleep apnea with these outcomes. Maybe we should not use the same biomarkers for men, for women, for young and older patients. It's probably stupid to take the same AHI threshold for a 20-year-old woman and for an 80-year-old man. Probably it's not the same threshold, probably not the same biomarkers that matter. And maybe there is a genetic predisposition also that interferes with that. So the next steps would be to use maybe artificial intelligence to really see which parameters are important to predict the 10 years outcome of these patients. And once we can really identify people at higher risk for this cardiovascular disease, we need to show that by treating specifically this subpopulation, we will have a positive impact on their cardiovascular risk. And this will be the holy grail to show that we can identify the people, and when you treat them, they get better. This is what we should do. And I would like to thank you for the attention.
Thank you so much for this talk. I'm very impressed by the detailed, very, very detailed assessment of sleep parameters in this study, and also as a neurologist by the results. But as we have not much time now, we have time for one question, and after the next talk, we have a 20 minutes break, so all other questions can be put there. So one burning question now. Yes.
How many incident events, cardio and cerebrovascular, occurred during those 4.5 years follow-up? And have you already looked at the association between objective and subjective sleep quality you just mentioned, which seems very interesting?
Okay, so yeah, at 4.2 years old, years of follow-up, we have about 100, a little bit more than 100 in the composite outcome. That's why we have to put them all together, because it's not so high, but we already have something significant, which was a bit of a surprise for us. So it's not huge right now, but now they're getting much older, and we can see that at 10 years, many of these people are over 80 years of old, and we have much more cerebrovascular disease. and also the cognitive decline in the neuropsychological tests are tending to go down. And so now it's the exciting time to really, we have more events, so we have more power to detect these events. And the subjective and objective sleep are two different things. And I think we should really treat them differently. Both are important, but they are very different things. Even we did some studies about the subjective sleep duration, how people estimate, who are the overestimators, the underestimators, and they can be huge differences also. So quality is very different on subjective and objective. Older people tend to rate their quality of sleep not so bad, but when you look at their actual sleep, it's terrible. And when even sleepiness, daytime sleepiness, assessed subjectively, it's going down in older people, whereas you see that their sleep is just a catastrophe. And so yeah, it's very different, and we should better try to understand what really matters to estimate that your sleep is good or not. And I still don't know that.
Thank you. So thank you, Professor Heinz, for this very interesting talk. And I would really encourage you to put more questions to all presenters at our break, or even enclose you in a break room, because I think there's many informations that we get today, and there's room to share. Okay, so I will introduce the last presenter before the actual break, which is Dr. Zander. He's a psychologist and research fellow at the Department of Psychiatry and Psychotherapy at the University Hospital Leipzig in Germany. He's a member of the LIFE consortium, so we do have here another cohort study, and he has been involved in the planning and investigation of the LIFE Health Adult Cohort Study. So this is I guess it's a subgroup of the LIFE study. And he coordinated the psychiatric diagnostics, the EEG examinations in the LIFE study, as well as he was primarily responsible for the sleep recordings. So this is why we invited him, and very happy to hear from him today. So Dr. Zander, please.
Yeah, thank you very much for the kind introduction. Although I must say I feel slightly misplaced in the program, because I now present data from an older study, and I'm very impressed with what my predecessors had to say, and now I make a methodological step back, I guess. But nonetheless, so as you said, here's my conflict of interest. So I have none personally, but I'm speaking on behalf of the LIFE consortium. And the LIFE study, so this is a cohort-based study from Leipzig, population-based cohort, but as you can see, again, like in the former talk, we have more or less, of course, one very large focus of the study was cognitive decline and depression in older age. So this population, 60+ years, is very deeply phenotyped, and the other ones mainly got a core program, which also includes several, like in the national cohort, various examinations. But the baseline examination from which I will present data took part in 2011 to 2014, so before the first national cohort. And we have also now a follow-up, but it's not yet analyzed. Okay, since we wanted to speak about some methods, so I also brought to you what we did for sleep assessment in LIFE. We have some subjective sleep parameters, the before mentioned Pittsburgh Sleep Quality Index and the Epworth Sleepiness Scale, and also a chronotype questionnaire, the German version of the morningness eveningness questionnaire. Just for one slide example, for example, here the Pittsburgh Sleep Quality Index. So as expected, quite a lot of people rate their sleep as good. Some have some problems with sleep, and about 10 or 8% say state relative or clinically relevant sleep problems. More or less women more than males, and the older more than the younger group. For objective sleep assessment, we used one of the devices that in the first talk were presented in the wearable device situation. This is the SenseWear Pro 3. I must say we were quite enjoying this device during the study. We did a validation study in the sleep laboratory, and it also had, you could use the data on your own. You didn't need to send it to some app or something like this. But unfortunately, in the meantime, this company has been bought and they are no longer available. We combined them with sleep diary and used them for a 1-week actigraphy recording. And I thought that I put some methodological information here. So this is not from the from a SenseWear, but I used it. It's from another actigraph. I just used it because it's a nice visual. So typically, this SenseWear would be sleep would be analyzed in such blocks from noon to noon, so from midday in one day and then to the next day, and all sleep would be added. So day sleep and night sleep all combined, which I found at the time a little problematic because I did not want to combine day sleep on Sunday morning with day sleep on Saturday evening. So we did it, we used the information from the sleep diary to first determine what is night sleep. So based on the information that the subjects give, which is in some recordings quite good to have this information, because apparently many people tend to fall asleep watching TV and then they get up and then they go to bed. So we use this time which they stated as their go to bed time for the night sleep. And then the interval between the individual night sleep is then what we use for assessment of daytime naps. So we cluster all the daytime naps on the calendar day together. Here, for example, this is what we had for total sleep duration. So it's night-day cycles. We always use, or we combined the night sleep with the following day sleep. And as expected, again, there's quite a lot of people who have what you would consider a normal sleep. So there's no real, no objective measure of sleep that you would say this is normal, but you normally find that between 6 and 8 hours would be a good sleep, and you have quite a lot of people with shorter and quite a lot of people with longer sleep duration. So what I want to talk about in more detail is now two projects which we did with this sleep data. So the first lab project was on the association of vitamin D deficiency with subjective and objective sleep parameters, which has been published in 2019. So a little background. So vitamin D is not one vitamin, so there's a group of vitamins which are mainly involved in calcium homeostasis and bone metabolism, but had been suggested, and there's more and more research on it, that they are also involved in quite a lot of other conditions, for example, sleep disorders. That's why we were interested to investigate the association in this live population where we had all the relevant information. Because before we did the study, there had been a few published papers on the association between vitamin D and sleep, most of them using subjective sleep evaluation, which could show that higher vitamin D levels were associated with, for example, shorter sleep onset, but more subjective complaints, and also longer sleep duration. The few studies with objective evaluations also showed that higher vitamin D levels would be associated with, one could say, better and longer sleep. However, there were quite a lot, or some methodological limitations. Many of these populations used very specific populations, for example, only older men or only members of certain races. and some had very large gaps between the measurements. So one study, the gap was 10 years between when you measured the vitamin D and then when you measured sleep. So we thought it would be good to analyze this in a larger sample, not such a specific population, and this very close assessment of sleep and vitamin D. So from the baseline program, we took those sleep questionnaires and blood sampling information, which gives information about concentrations. And then the actigraphy, one must say that in live actigraphy was an optional assessment. So everybody who had performed the core assessment was then asked if they would be willing to participate in this optional program, and about 1/3 of the population. So we cannot use 10,000, but we have less people with actigraphy. We used, I don't need to introduce, I think these parameters, we have heard quite a lot of this. So I called it mid-sleep time. This is what we had heard about chronotype. So the average between sleep onset and sleep offset. And then we classified vitamin D. You can see, as one would expect, there's not so many people, only about 1/5 of the population who has what would be considered sufficient vitamin D levels. This is not uncommon in our part of the world. Quite a lot of people have insufficient, or what we would consider a deficiency, but also quite a lot have a vitamin D deficit if you look at their concentrations. And then we tried to bring this together with the sleep parameters. We did regression analysis, and the results of the regression analysis found an association between vitamin D concentrations and night sleep duration. So a bit longer night sleep duration with better or higher vitamin D concentrations. Somewhat earlier mid-sleep time with higher vitamin D concentrations, and there was an interaction between gender and wake after, or concerning wake after sleep onset, interaction between gender and vitamin D. So, males, another association than in females. The other parameters did not show any interact or any association with vitamin D concentrations, and also the subjective scores, so the PSQI score and the ESS score did not show an association. So in the next step, in the next live project, we asked ourselves if the association between vitamin D and sleep could be influenced by depression. The study, we don't have exact diagnosis of depression, but we have a questionnaire. So could say depressive symptomatology, the amount, the score, it's the SASD score. I will show, but first, some background information here. Vitamin D has also been linked to mental disorders. So there is a high prevalence of vitamin D deficiency or insufficiency in mental disorders, especially in depressive disorders. And some studies, there are not so many of them, have also looked at depressive disorders, and apparently there are some hints that supplementation of vitamin D could lower the risk of depression. So our question was if the association between vitamin D and sleep would be mediated or moderated by depressive symptomatology. And we focused on, in the actigraphy, on the two sleep parameters which had shown an association. And as I said, for the depression, we used the Center of Epidemiological Studies depression scale. So the moderator analysis did not show any moderating effect. So I only present mediation models. We did one model without covariables, so just with the 3 parameters, and there you could see not very high, but at least significant associate or effect of vitamin D on night sleep duration, a stronger effect of vitamin D on the depression scale, but interestingly, no significant effect of depression on night sleep, and therefore also no indirect effect of vitamin D via depression on night sleep duration. However, in the model with covariables, even the direct effect did not reach significant anymore. The same with mid-sleep time. So I didn't change the heading, but it's mid-sleep time now. Here again, you have here you also in this analysis, you had no direct effect of serum vitamin D levels on mid-sleep time, and also then no indirect effect again. So a little different to the other study. So in one study, we found some association between vitamin D and longer and earlier night sleep. In the other, we found that it was not moderated or mediated by depressive symptomatology. One could explain the difference between the two, between its 2 different statistical approaches. And one must also say it's 2 slightly different samples in both analyses due to inclusion-exclusion criteria. But I would conclude with a notion that was presented in the last talks also, maybe especially in the context of depression, which we diagnose based on subjective impressions about mood and about all the other things. Maybe here subjective sleep quality might be a better outcome or a better parameter than these objectively quantified sleep parameters, because there is more and more research showing that even in people with insomnia, it is only in very severe cases of insomnia that you find a very disturbed objectively sleep, and no so much interaction between how the people rate their sleep and how it can be measured. And I would say, contrary to the former talk, maybe it's not that you say they rate their sleep good and it's horrible. Maybe it looks horrible, but it's still good. Maybe this way around. Yeah. So I hope that I made up a little time so that we can have the break. And I thank you for your attention and all the people who have been involved in the live study.
Thank you very much, Dr. Zander. So we actually moved into brain health here. Are there any questions? Andrea? Did you? No.
I may have one. Good morning. I was just wondering, I'm not at all too much, I don't know too much about vitamin D, but I was wondering, and I may have missed the beginning of your talk too. So, you know, what were those kind of a specific pathway you were thinking of that may link sleep and vitamin D? And for example, you look at depression as a possible mediator, and are you thinking of other mediator potentially?
Could you repeat the question? I didn't understand the last part.
Oh, yeah, sorry. So I was wondering whether you were thinking of other mediators than depression that may explain, you know, some of the pathway on how sleep and vitamin D may be, you know, linked together.
Of course, there might be several of them, but coming from psychiatry, we were interested in this specific thing because there's so much, so sleep problems are so common and so important for many patients, and especially in depression. It's often what people complain most about. Okay, the mood is bad, but the mood is sometimes patients consider their mood following of their sleep problem. So they would say, if I could sleep better, everything else would be also better. So that's why we were interested in this association. But of course, there are quite a lot others that one could expect. But we have not analyzed them in this project.
Thank you.
Thank you very much. So all other questions might be put now at break time, which we will start now. And it will a bit shorter than planned. It will be 10 minutes, so until 11 a.m. So 10 minutes for exchange and coffee. And you can actually point out your wishes. Do you want to discuss in this large forum, or do you want to use break rooms? You can just tell us what you want.
Maybe just open mic for everyone in this round, so we don't have to select, and everyone might get a coffee to prevent sleep.
I guess that's a good idea. So we're open for questions, coffee, snacks, and so on, and we will restart at 11.
May I ask a question to Christian Sander?
Yeah.
You looked at the mediation effect, but have you looked at the direct effect, CSD score, and sleep length, or mid-time sleep? So is there an effect of severity of depressive symptoms on sleep characteristics?
So in this project, it was only at the moderator, but so in the mediation model, we have not associated depression directly with the actigraphy data, just for the moderation.
Okay.
Always in those projects, you apply for what you are allowed to do, and you can only do this, and you're not allowed to deviate far from what you have applied for.
Yeah, life is not so easy in life, I know. And I have a comment to Raphael. I think it would be worth actually at least looking at objective and subjective sleep quality. And if the answer is no, these are complete different issues, as you mentioned, which might be very true, then this is clarified, because then you gain the information that these are two different concepts that do not or only very partially overlap, and you have two predictors at hand you can use and work with. Otherwise, if you do find at least some overlap, so that those with worse subjective sleep quality actually do have a little bit less delta activity, this would be an interesting finding, because then you have a bridge of into explaining subjective perceptions, and this is why. So both answers are valid, both answers are interesting, so you can't do anything wrong.
So this is a very interesting point, and we've actually further investigated that. So in the large cohort, large for us, not for you, we saw a difference, really a difference in the sleep perception when we just take the 6 electrodes that we put on the head. So there was a clear difference. And in clinic, we see that all the time. People say, oh, I haven't slept for a month. No. And the partner says, oh, yeah, sometimes I see you snore and sleep. But the person, no, I was here, I was not sleeping for the whole night. Same way when we do the recording, the clinical recordings, you'll tell me, okay, I haven't slept for the whole night. And when we look at the video, we say, okay, look, here you look like you're sleeping. And we see this delta wave, we see the sleep cycle. And so we were wondering, what's the matter? How can it be so different? So my colleague Francesca Ciclari, she's specialized in the consciousness. And what is consciousness, and how do you measure consciousness? And sleep is very interesting. And parasomnia, like sleepwalking, is very interesting models to measure consciousness, because people can do things but are not fully conscious. So what she's doing is to have high density EEG, so 200 electrodes over the head, where you can see really that sleep is not a homogeneous state. And we knew that before, that you can have some parts of the brain that are still active while others are already sleeping. this is true for daytime when you think you're awake, but you see some part of the brain, especially when you're deprived, it already sees some part of the brain, and you can see that it's associated with a decrease in performance. But the same for sleep. And what she recently found is that people who say that haven't slept for the whole night, they actually have a higher beta activity in some parts of the brain. And so they are probably right that, I mean, 95% of the brain is sleeping, but there is a small part that is still awake. And this gives them consciousness, which is very, very uneasy to cope with during the night, because you feel that you're here, you're bothered to be here awake, and actually your brain is sleeping, because during daytime they don't complain so much of sleepiness. Because so this is a very, very complex area, and I'm glad that my colleague is actually investigating that.
Interesting stuff. Yeah.
Yeah. So high density EEG is very different from just the basic EEG that we would do in a polysomnography.
Yep. Yeah, definitely. And others for Jan Kantler. Would you think, given what Raphael Heinze showed on the delta activity, in addition to REM versus non-REM detectable by algorithm, would you think it's possible to come up with an algorithm as a proxy for a lot of delta versus little delta activity based on the SomnoWatch recordings as a proxy, additional proxy probably to REM non-REM?
Well, the REM non-REM detection is currently done by a neural network. And for a neural network, you don't know what it actually looks at. So you can train it on some data, but you don't know what information is actually taken from by the neural network to estimate this REM non-REM classification. So if it is possible to detect data active with a neural network, I cannot tell. One just has to try. You cannot know in advance because you don't know what the neural network will look at. Otherwise, the delta activity is associated with the deepness of sleep. So if it is really deep or light sleep, I think that cannot be easily identified from the motion activity, because even if the sleep is not really deep, but it is light sleep type 2 or so, then there's also little motion activity. So from the accelerometer, I think it will be hard to identify delta activity. Yeah, but
probably heart rate variability is the main difference between REM and non-REM.
But if you take into account heart rate, I think that there's indeed the option to get some proxy of delta activity from that. But I'm not familiar with heart rate variability or certain timescales of heart rate variability with delta activity. That is something.
So it's more with sleep stage REM non-REM. I don't think delta by itself would be difficult to identify from a peripheral detectors, but the REM non-REM dichotomy, I think, is obviously quite easy to do with the type of network that you have.
Yeah, the REM non-REM is easy to do, and then you can always say that there is higher delta activity during non-REM than during REM. This is correct, yeah. But yeah, one has to check if there's also some better way to estimate the delta activity. I cannot really answer now.
Yeah, because I was asking if you do it stepwise. So given the large amount of data in NARCO, if you run REM versus non-REM, and among the non-REM proportions have some additional algorithm to get a proxy on either delta activity or deep sleep stages, I wouldn't necessarily label this delta and on, but deep sleep stages, something like this, to show the variance or separate the non-REM part, and this would be a major gain, because as Raphael and others showed, that these delta activity, or the more the delta activity, are related to interesting endpoints in clinical view. And so this might be worth having a stepwise approach.
Yeah, I agree.
Well, thank you all very much for such a engaged discussion during our short break. I'm now very happy to start off our second part of our sleep symposium, which will lead us to a discussion about common sleep disorders, as well as sleep characteristics with regards to brain health, especially the aging brain, cognition, and dementia. And without further ado, I'm very happy to again actually introduce our first speaker of the second part, who is Andras Pirai. You've already heard about him. He's from the Institute of Epidemiology and Social Medicine at the University of Münster. And now in his second talk, he will speak about the prevalence and characteristics of common sleep disorders based on findings from the population-based BiDirect cohort study. Andras, thanks for talking again, and over to you.
Yeah, thank you for the kind words. And yeah, I start. Sharing screen. Okay. Yeah, so we're talking about what is a large study, what is small study. BiDirect is smaller than the others, as you mentioned. So this is a limitation, and I will talk about some classical epidemiological analysis about the most common sleep disorders. And first, those of you who do not know the BiDirect study, this is an observational cohort study with the aim to explore the bidirectional relationship between depression and subclinical atherosclerosis, which involves three groups, three cohorts, and I will concentrate on the control group now, which was a random sample from Münster of individuals between 35 to 65 years old. So it's worth keeping in mind there are not too old people and also not too young people in the cohort. And also the subjective sleep was a measure with the Pittsburgh Sleep Quality Index. And yeah, the baseline was conducted it started in 2010, involving in this normal cohort more than 900 subjects, and then 32 months later came the first complete follow-up, where the majority of the subjects were participated again in the study. And during this follow-up, we conducted the polysomnography, and from that follow-up, about 250 participants accepted the invitation to the sleep lab. So I just to show you some of the characteristics of this sample with polysomnography. Yeah, as I mentioned, this is a middle-aged population, and I think this is quite a typical population and represents the general population. There are lots of people who had overweight, and hypertension was also quite common. And
you're not in the presenter mode, so we can't actually see your slides.
Oh, really?
Yeah, but it was nice to listen to you, so it didn't actually.
Okay, but you should tell me just a moment.
Yeah.
Sorry about that.
Yeah.
How come is it? Because it says it. Okay, I stopped sharing and I start again the sharing. Okay, share screen. Is it okay now?
Yes. Yeah. Working.
Okay. So Yeah, so sorry about that. So I was just showing you some of the basic characteristics of this sample, and I started to talk about the sleep characteristics that we measured. So the total sleep time was somewhat limited, which is, well, it's actually a limitation laboratory-based measurements. Of course, these subjects have often a problem falling asleep with all this equipment attached to them. Also, there's a schedule. They need to go to sleep at 10 o'clock, or this is the lights off time. Yeah, the sleep efficiency was okay, but I think that was also somewhat impacted with this schedule in the sleep laboratory. The deep sleep amount was quite normal. And here's the apnea-hypopnea index and the periodic lab movement index. And those with the bold characters are just where we see gender differences, significant gender differences. And there's also the Pittsburgh Sleep Quality Index measuring the subjective sleep, which was more impacted among women. And just we were talking about our ability to perceive the sleep duration. So it just included this slide to show you. This is a blend Altman plot showing it is the mean of the objective and subjective sleep duration. And this is when the individuals at the morning were asked, okay, how was your sleep and how much did you sleep? So this is not from the Pittsburgh Sleep Quality Index. This is right after the sleep in the sleep lab. And this is just how the standard way with the polysomnography, the sleep duration was calculated. And in the y-axis, you see the difference between the two. So actually what's interesting that there is no constant bias. So on average, they are right, the subjects. But the issue is, of course, so there are overestimators and underestimators of sleep duration of equal size. But the issue is, if you see the two standard deviation lines, that in the individual level, there are huge discrepancies between what we objectively measure and what they report. So it's like there are a lot of subjects who just say that we 2 more hours of sleep or 2 less hours of sleep. And of course, this is a question what Raphael Heinzer also talked about, how we measure sleep objectively. What do we look at? This was a standard polysomnography, so this was not a high definition EEG, but there are probably subtle differences that we miss during a standard polysomnography that actually influence the sleep duration, how we perceive it. And I think it's there was no differences between men and women, so they perceive sleep duration similarly. Okay, and yeah, let's talk about the common sleep disorders for sleep apnea. As you may imagine, there was a strong association with the body mass index, and also it was more common among men than in women, which supports earlier findings, and it was quite frequent. So if we measure sleep apnea on the standard way with the number of apneas and hypopneas, then we see that what we call moderate amount or moderate degree of sleep apnea, which is more than 15 per hour, then you will see that about 15%, and those with the severe, so-called severe degrees, it's more than 6% in this population. It's also interesting to see that the most commonly asked questions are that do you snore? And actually, when they recall it, even with this severe degree of sleep apnea, about 60% do not report any snoring at all, which is, I think it's important to keep in mind, and it draws attention to the importance, but also Rafa Heinze said that we need sophisticated scoring systems, because snoring, which is very common and in sleep apnea, especially in severe sleep apnea, may not be unknown to these subjects. The other important question is that the ability to stay awake, and those with severe sleep apnea report more frequently. That maybe less than once a week I really feel like falling asleep, but the more common complaints are just at the same level as those without sleep apnea. And if you look at the individual independent predictors of moderate sleep apnea, it was interesting to see that in this sample age was not a predictor, maybe because of the limited age range. And yes, among men, so the man gender was a strong predictor, also BMI. I think it's important to recognize that kidney disease is also a strong predictor of sleep apnea. This has been reported in a population-based setting, also in the HypnoLaus study. And these are individuals not with end-stage renal disease, but with some report that, yeah, I have some renal disease, but the GFR is not that low, and they are not on renal replacement therapy. And this is also supported in the study of health in Pomeranian, in the SHIP study, which I'm not sure it was actually reported, but because I also analyzed those data, if the GFR, the lower GFR, lower glomerular filtration rate, is also an independent predictor for sleep apnea in that study. Alcohol intake seems to be also, although it's not, these values are not, do not reach significance, but I think it has to do with the sample size, because alcohol intake is also seems to be a predictor in other studies, like in the SHIP study. And it's known that alcohol is a muscle relaxant, and it may have also other factors that could influence or predispose to sleep apnea. And the snoring, the frequency of snoring as reported was also a predictor. But it was interesting to see that hypertension, diabetes, depressive symptoms, subjective sleep quality, or difficulty staying awake were not independent predictors. Of course, I think it goes back to the question, how should we define sleep apnea? And as Rafael Heinze said, and I completely agree with him, that this is the apnea-hypopnea index is a very crude estimate and may not necessarily differentiate those with high risk of cardiovascular disease from those with who actually may have with our current clinical definition a moderate sleep apnea, but without any enhanced risk, increased risk of cardiovascular diseases. Okay, and now a bit periodic leg movements in sleep, which is quite rarely mentioned, even though it's very frequent in population-based studies. Again, this is confirmed by the other German study, the SHIP study, also in the HypnoLaus study, that if we measure, and this might again be a crude measurement of the PLMS, the PLMS index, with the usually used 15 per hour cutoff, more than 1/3 of the subjects have PLMS, which is basically this periodic kicking during sleep. And this is an ongoing debate if it has a relevance. Is it a disorder or is it just a phenomenon without any particular risk? There are some studies, longitudinal studies, showing that those with PLMS have an increased risk of incident cardiovascular events. Other studies do not show this. So I think this is something worth looking at and in the future as well. But in our study, we did not find any relationship with hypertension or diabetes or with depressive symptoms, even though there was a tendency to see more PLMS among those who were taking antidepressants. It's well known that it's associated with restless leg syndrome. And it's, I think, also interesting that, again, BMI is a strong independent predictor of this sleep disorder or phenomenon. And there's a very strong association with age. So it's continually increasing in every age group. And it's also more common among men, even though it's not significant. But if we look at the other studies, we clearly see this male predominance in the PLMS, which is interesting because they often mention PLMS as something associated with restless leg syndrome. But it's more common, much more common than restless leg syndrome. And with RLS, there is the female gender, the women have more RLS, and this is reversed with PLMS. So obviously something else is going on. But yeah, in future studies, we hopefully see if this is actually a predictor or a risk factor of other incident diseases, or maybe it might not be causally linked to other diseases, but it could still be a marker for neurological diseases or cardiovascular problems. We will see that hopefully in the future. Okay, so again, just looking back at what we've seen, that the objective sleep parameters are worse among men than among women. Deep sleep is reduced among men. They have more sleep apnea. They have more PLMS. On the other hand, which is interesting, of course, that women still have worse subjective sleep. And why is that? And we know that women have more insomnia complaints, even though they retain, as they get older, more deep sleep, more restorative sleep. And we don't really know the reason for that. And here's the Pittsburgh Sleep Quality Index scores, showing that women have in each age group higher scores than men. And if you use the usually applied 5-score cutoff, we see that almost half of the subjects in the sample had poor sleep. But of course, this is a quite liberal cutoff. So if you have a few complaints, you can easily reach a 5-point score. But it seems to be quite common, and women have among women is substantially increased compared to men. And what are the predictors for poor sleep quality as subjectively perceived sleep quality? it was interesting to see that age again was here not strong or was not a predictor at all. And yeah, men have better sleep when subjectively seen, and depressive symptoms was the strongest predictor. And you need to be a bit careful because there's some overlap. If you ask, we use the Center for Epidemiological Studies depression scale, and of course there's an overlap between the subjective sleep quality questions and the questions about depressive symptoms. But even if you remove those questions, you still see this strong association. And what was interesting is to see again, which for me was somewhat surprising, that sleep efficiency and the polysomnogram was also associated with sleep quality, which is a quite crude estimate of the overall the sleep efficiency of the overall sleep during the night. It's basically the ratio of the actual time spent sleep with regard to the time spent in the bed. And I was not really expecting it because in the sleep laboratory it's a bit biased because of the time constraints. But still, it was significantly associated with subjective sleep quality. And again, this was something that can also be seen in the SHIP study. So it confirms this association, and I think it's worth looking at further. And I think it's somewhat good news because the actigraphy can also measure sleep efficiency, because you need a sleep-wake cycle to measure the sleep cycle. And last but not least, restless syndrome was also a very strong predictor of subjective sleep in this population-based sample. So I think it's a nice addition for the our current knowledge, what are how common sleep disorders are, and what associations do they have. And as a summary, sleep apnea and periodic leg movements in sleep were not associated with subjectively felt poor sleep or sleep quality. Also, they were not associated with hypertension and diabetes, which leads back to the question, how should we screen or define clinically relevant sleep apnea? And there were profound sex differences in the prevalence of sleep disorders, namely men had more sleep apnea and more PLMS. Deep sleep, while women had subjectively poorer sleep. And yeah, thank you for your attention, and thanks for everyone involved in the BiDirect study.
Thank you very much, Andras, for another excellent, very informative talk. We're quite advanced in time, so maybe we could do one pressing question. Otherwise, I would suggest please use the chat or save your question for the overall discussion at the end of this part. So is there one question that you need to have resolved now? Okay, that does not seem to be the case. So save your questions. We're going to come back to it. And it's now my pleasure to jump straight away to our second presentation of this part, who is Dr. Anton Weiss, who is a research scientist at the Department of Psychiatry and Psychotherapy at the University Medicine in Greifswald. Dr. Weiss has a background in biomathematics, bioinformatics, and computational biology, and we're now looking forward to his talk. You can see the title already on the relationship between Alzheimer's disease-related brain atrophy patterns and sleep macroarchitecture. Dr. Weiss, over to you. Thanks for being with us. We cannot hear you.
Yeah, sorry. I just
perfect.
I hope you can see the title screen now. Okay, yeah,
Yes.
thank you for the introduction. As you said, my name is Anton Weiss, and I work as a researcher at the Department of Psychiatric Psychotherapy at the University of Medicine Greifswald. And today I wanted to give you a quick overview of my current work in which I investigated AD-related brain atrophy patterns on sleep microarchitecture values. Alzheimer's dementia is, just to give you an overview, a neurodegenerative disorder, mostly affecting the elderly, with an estimated 82 million affected individuals by 2030. It is said to become a major burden on global health system and society in general. Currently, there is no cure or therapy available, which can reverse the disease's pathological processes. And while there have been some pharmaceutical advances, such as the slightly controversial amyloid beta antibody aducanumab, or the recently presented ginger pains inhibitor atuzanginstat, there have not been the great breakthrough everyone hoped there would be. Therefore, the currently only approach to delay the onset of the disorder is to identify and target early pathological processes and modifiable risk factors, such as obesity, smoking, and gingivitis, or sleep. Sleep in particular has been gaining some attention, or more and more attention recently, in both the public image and the scientific community, with current evidence suggesting a complex bidirectional relationship between the two. In the one directions, various sleep markers were found to be associated with AD-related biomarkers, increased sleep atrophy and dementia risk. And the other, subjects with AD often report the presence of low sleep quality, high incidences of sleep disorders, and AD-related pathology in particular was found to be negatively affect various sleep parameters. To shed some further light into this, we have investigated the effect of sleep macroarchitecture, specifically the proportion of total sleep time spent in stage 1 and 2 non-rapid eye movement sleep, slow wave sleep, and rapid eye movement sleep on Alzheimer-related brain atrophy patterns. For this analysis, we have used MRI and polysomnography data from 711 individuals from the SHIP-Trend population-based cohort. To give you a quick overview of the cohort, SHIP-Trend is part of the Study of Health in Pomerania, a group of independent population-based cohort whose participants were randomly drawn from local registries in the northeast of Germany. SHIP-Trend itself started in 2008 and includes around 4,420 subjects, all of which were invited to undergo an MRI examination and a one-night polysomnography examination performed in a sleep lab. At the end, we had MRI measurements from around 2,150 subjects and polysomnography measurements from 1,264 subjects. The sample we analyzed here is a subset of 711 participants, for which we had both MRI and polysomnography measurements, which had a total sleep time during the polysomnography of more than 4 hours and didn't suffer from multiple sclerosis or reported a stroke. The sample had a mean age of 52.5 years, a fairly balanced male to female ratio, and was generally slightly healthier, more educated, and had a slightly higher mean income than the remaining SHIP-Trend sample. Going to our AD score, the score is based on the theory that the Alzheimer-related neurodegenerative processes affect different brain regions to a different degree, creating a sort of telltale global pattern that can be assessed via MRI. This approach is not unique to AD, but has also been similarly used for example, brain aging, among others. To calculate it, we have performed an L2 penalized logistic regression on segmented T1 MRI readings from 374 subjects of the ADNI1 screening sample in order to create a classifier which optimally separated subjects with Alzheimer from cognitively normal ones. In other words, we trained a model which calculates the odds of a subject having AD given the individual specific cortical and subcortical MRI measurements. We found that the resulting classifier had quite a high accuracy on the ADNI1 sample it was trained on, but also on OASIS, which is another independent AD cohort. But as AD, Alzheimer-related neurodegeneration, does not suddenly appear with the onset of the symptoms, but slowly builds up starting years before its onset, the score cannot only be used to differentiate subjects that have AD from subjects that don't, but we can also use it to create a continuous score, which quantifies how much a healthy individual's brain resembles an AD brain. And with that, summarizing the pre-symptomatic neurodegenerative processes happening already. As a quick example for an application, colleagues of mine recently have used the score to identify a favorable effect of periodontal treatment on Alzheimer's-related brain atrophy, which is incidentally a similar result to what was recently also reported in the press release of the Atuzagin-Stat trial, where they found that the ginger pains inhibitor basically had a favorable treatment on AD in subjects suffering from gingivitis. Coming back to our current sample, to give you a small feeling of the AD score, I've summarized some of the potential risk factors for the onset of AD here and investigated how much additional variance they explained compared to the base model, which was just adjusted for age, gender, intracranial volume, and total sleep time. As you can see, we can see that quite the strong effect of different lifestyle factors, specifically smoking. But interestingly, we can also see the sleep macroarchitecture markers, and specifically NREM1 and slower sleep, to explain quite a lot of variance on their own. In fact, actually more than the metabolic or the socioeconomic factors. This can also be seen in the actual regression analysis, where we have found a significant negative association between the proportion of total sleep time spent in slow wave sleep with increased Alzheimer's-related brain atrophy. This effect remains stable even after we adjusted for the various confounding factors. And while we cannot infer any causality here, partially because of the cross-sectional nature of the analysis, but also because of the suspected bidirectional relationship between the two, in a biological framework, these results are in line with the current research. Slow wave sleep, to give you a quick background, represents the sleep stage in which the brain shows the greatest decrease in neural activity compared to the waking stage. It acts as a sort of counterbalance to the high neurometabolic activity and metabolic stress that the brain experiences during the day, sort of allowing it to heal and regenerate and replenish itself in preparation for the next day. Regarding Alzheimer in particular, slow wave sleep has been associated with cellular repair mechanisms from oxidative stress, decreased expression of APP, the amyloid beta amyloid precursor protein, and a drastic increase of glymphatic clearance of cerebral metabolites, among which also amyloid beta and tau. Furthermore, we have also found, or mouse experiments has also found, that amyloid beta plaques in the brain resulted in reduced slow wave sleep, which was reversed after their removal. And in adults for whom slow wave sleep was artificially hindered, it was found that they showed acutely increased amyloid beta concentration in their cerebral spinal fluid. Regarding the borderline association we found with MREM1, our initial explanation was that this might be an indication for low sleep quality or sleep quality related effect. In other words, that increased proportion of sleep spent in stage 1 related to reduced sleep quality, which correlated with increased AD related brain atrophy. We have therefore looked at other objective and subjective sleep metrics of sleep quality, but to our surprise, could not identify any significant relationships. A result or possible reason for this might be the first night effect of the polysomnography. We unfortunately only have measured the subjects for one night, and previous research has found that while this does not really have a great effect on slow wave sleep, it was found to influence total sleep duration and REM sleep. Another might be a power problem, where in combination with the relatively young age of the cohort, the effect is too small to be identified in the sample. A third reason, which sort of also goes into this power problem, is that the metrics on their own might not be very informative, and that a composite sleep quality score or microarchitectural measures might be more relevant here. The same can be said for the REM results or results with REM sleep, which have been recently associated with high, or where low REM sleep has been recently associated with higher dementia risk. But we couldn't find any results here, which was also recently observed in the Framingham cohort, which did not find any associations between REM sleep and various other volumetric brain measures. In conclusion, we have found a significant association between slow wave sleep and Alzheimer's-related brain atrophy in one of the larger studies of this kind, using a brain morphology-based AD marker that, while analyzing the brain as a whole, takes into account subtle but widespread AD-related deviations of regional brain structures and can easily be acquired using MRI. On the other hand, we have only found a borderline association with stage 1 NREM sleep and no association regarding REM sleep, which warrants further investigation. I thank you very much for your attention, and I'm looking forward to any questions you might have.
Thank you so much, Dr. Weiss, for this super interesting presentation. We do have time for questions or comments, so if anyone has one, please feel free. Dr. Berger?
Have you analyzed brain age in SHIP already, and what is the difference in explaining the variance between brain age measures and the AD score? Because it seems rather similar, but a different approach. So the common brain age algorithms might even go further, or I'm pretty sure you have some brain age analysis done too in this cohort.
Yes, we have looked at brain age, but we couldn't find that effect when we looked at brain age. The scores, yes, I agree, the scores are quite similar, but are a little bit, so the brain age score is a little bit more generalized because it was trained to look at global brain atrophy patterns. So maybe also the general age-related patterns, but also including AD. So you can say that the AD score is included in the brain age score, but the AD score is more tuned to look at Alzheimer in particular. So there is a slight overlap, but they were tuned to slightly different questions, basically.
Okay.
Any other questions? Feel free to unmute.
Have you had any spectral analysis of the brain EEG to see the microstructure of the brain?
Yes, I haven't had them myself, but there's also colleagues of mine are also currently looking at that. So there should be some results soon.
If you have already something with N3, because the clearance of the beta amyloid is supposed to be cleared during the delta waves, according to the theory of the glymphatic system.
Yeah.
So maybe it would be even more significant if you focus on objectively measured delta waves.
Yes. Yeah. This is definitely something that we're currently doing, where we are looking at the delta waves. We also wanted to look at sleep spindles, because there have been some results in that regard, which sort of might explain the lack of also a result with NREM2. That NREM2 as a duration factor is not really interesting, but more the microarchitectural components of it. But this is definitely something we are busy looking into as well.
Brilliant. Thank you very much again, Dr. Weiss. And we now move on. We stick to the topic more or less. And it's now my great pleasure to introduce to you Dr. Susanne Savia. She is a researcher in the Department of Epidemiology of Aging and Neurodegenerative Diseases at the University of Paris in France, and also affiliated with the Department of Epidemiology and Public Health at the University College London. She holds a master in general engineering and a PhD in public health and epidemiology. And we're now curious to hear the results on sleep duration from mid to late life and dementia risk based on findings from the Whitehall study 2. It's my pleasure. Please, Dr. Savia, go ahead.
Thank you for this introduction and for inviting me for this very interesting symposium. So first of all, I would like to step back a bit and talk about dementia. Because this is quite a specific disease that is characterized by a very long preclinical period that is estimated to last between 15 to 20 years. And during this period, there are an increase in several brain abnormalities, starting with habitat deposition, then to pathologies that then will end up by neurodegeneration. That then we will, at this stage, we might start seeing some cognitive impairment that will develop up to functioning incapacities when dementia diagnosis will be given. So as you can see, during this long period, there are a lot of pathological changes that are very important to take into account when studying dementia. So this is a very simplistic representation of cognitive function during life. So first there is this neurodevelopment, then there is a kind of plateauing when in adulthood, and at some point people start to see their cognitive function to decrease. So you can have the very different trajectories, high heterogeneity and in trajectories of cognitive function. And when cognitive function reach a point, there is a dementia diagnosis that is given. But as you can see, given that dementia is an old age disease, there is most of the research so far has been conducted among older adults. This is what seems quite sensitive because we know that 5% of those age 65 years have dementia, and when we reach age 80, it's more than 30% of the population who have dementia. So when we want to see outcomes, of course, this is in old age. But what does it mean when we want to assess risk factors for dementia? We need to keep in mind that risk factors for prevention, primary prevention, are defined as factors that will have an impact on the development of the disease. So given this framework of dementia with a long preclinical period, studies based on in old age are likely to be to assess risk factors during the preclinical period of dementia. What does it mean in terms of interpretation of the findings? When we see an association between risk factors and dementia in older population, it is difficult to say whether this is a risk factors that has an impact on dementia development or whether dementia has an impact on the level of the risk factors. This has led the Alzheimer's Association to give some recommendation for studies to assess risk factors earlier in life in order to be sure that these risk factors are not the product of the preclinical periods of dementia, but are really involved in its development. So they precede the development of dementia. So now I will move on to the specific topic of this presentation today. And I just wanted to give you this type of context because it's quite important to interpret findings from other studies. So there are several meta-analyses that examine the association between sleep duration and incidence of dementia. And they all show this G-shape association or U-shape that shows that both short sleep duration and long sleep duration are associated with an increased risk of dementia. However, most of these studies are based on follow-up of less than 10 years, and among those with long follow-up, there are small samples with a few number of dementia cases, which lead to inconsistent findings. So current evidence is mainly based on studies with less than 10 years of follow-up, which means that it is really difficult to know whether what we see is reflect the impact of dementia on sleep duration, or whether sleep duration has an impact on the development of dementia. Furthermore, little is known on sleep duration between mid to late life and risk of dementia due to lack of studies with long follow-up. And from what we can see in the literature, there was no specific studies that examine the role of mental health in the association between sleep and dementia. However, we know that mental health is highly correlated to sleep duration and also a proposed risk factor for dementia. So this led me to examine the association of sleep duration at age 50, 60, and 70 with incidence of dementia, to examine whether change in sleep duration during this period was associated with risk of dementia. I also wanted to assess whether this association was explained by mental disorders, and then using an objective measure of sleep duration by accelerometer, I examined whether the association I found with questionnaire was also evident using these tools. So compared to what has been shown today, I used a very simple measure of sleep. And here, the main advantage of the present study is to be able to assess sleep duration several times over a 30 years period. So this is based on the Whitehall cohort that was established in 1985 when participants were between 35 and 55 years old. And over time, similar questionnaire and clinical exams were repeated every 5 years, which allowed me to use all this information to extract sleep duration at very specific age. So at age 50, for example, someone can be here, or here, or here. So I chose the measurement that was closest to this different age, so that I could see whether age modifies the association between sleep and dementia. To do so, I used this questionnaire with 5 categories. Unfortunately, I did not have enough people in the extreme of this distribution, so I had to group these 2 categories. So in the end, the category was 6 hours or less, 7 hours was okay, and after 8 hours or more. I was able to know the dementia status all over the follow-up using linkage to health record up to March 2019. And finally, a large set of covariates were available, including sociodemographic, behavioral, and health-related factors. So here is a description of the population with sleep duration at age 50. So in total, it was almost 8,000 participants. And among them, 15% had a sleep duration of 8 hours or more. And they were more likely to be women, to be non-white, and to have hypertension and mental disorders. Those who were sleeping 6 hours or less were more likely to have some cardiometabolic risk factors as well as mental disorders. Here is a picture of the distribution of sleep duration at each age. What we can see is that this is quite a similar pattern over aging, with a slight increase in those reporting sleeping 8 hours or more. However, we can also examine trajectories of sleep by using individual data at each age, and we can see that around 60–65% of the population has a stable pattern of sleep duration over time, whereas some other will have increase in sleep duration or decrease in sleep duration. I will now present the association between sleep duration at different ages and risk of dementia. I took into account separately first sociodemographic variable, then behavioral factors, and then I adjusted all models for this variable as well as health-related factors. What we can see here is the association with sleep duration at age 50 and incidence of dementia over a 25-year follow-up. And we found that those who were sleeping 6 hours or less had a higher risk of dementia. But although the hazard ratio was quite close for long sleepers, it did not reach significance, probably because of small power in this analysis. Similarly, when we look at the association with sleep duration at age 60 or at age 70, we also found that those sleeping 6 hours or less had a higher risk of dementia, although at older ages, when we include health-related factors, the association was attenuated. Then I looked at trajectories of sleep duration and incidence of dementia after age 70. And we found that those with persistent short sleep duration had an increase in dementia risk of 30%. The effect size was quite similar for persistent long sleepers, but again, the association did not reach significance. There was no clear pattern in the association with change in sleep duration and incidence of dementia. All these associations were adjusted with a large set of sociodemographic, behavioral, and objective measures of health-related factors. Then we repeated the analysis among those free of mental disorders before age 65. So why did I choose to stop assessment of mental disorders at this age? Is that there is a clear increase in mental disorders, particularly depression, in the preclinical period of dementia. So I did not want to exclude those who were in the path to dementia. So that's why I choose this approach. And when excluding these individuals, there were around 8% of the full sample. The association found in the main analysis remain significant. Then using data from the accelerometer sub-study that was set up in 2012 among 4,000 participants. In this study, the gene-active accelerometer was used to assess sleep duration, and this was done with the help of a sleep log. So this is a combination of these two tools with the algorithm available in DGEpi package that is based on the rotation of the wrist to assess sleep state that was used in this analysis. And we found quite a similar association as the one found when using the questionnaire data, so that an increase in risk in dementia risk was observed among those sleeping 6 hours or less. As you can see in the Whitehall cohort, we don't have long sleepers. This is also reflected by the accelerometer data. Here, the confidence interval is huge because we don't find people reporting such amount of time of sleep. So first, I will summarize the findings of the study. We found that short sleep duration in midlife was associated with increased risk of dementia, and the association was independent of a large set of sociodemographic, behavioral, and health-related factors. The association was also confirmed in analysis using accelerometer data, and there was no consistent finding for long sleep duration, which in fact requires that we use, it is important to have cohorts with more long sleepers, because I don't think we can conclude anything from the present study among long sleep, because first we were unable to separate those sleeping 8 hours or 9 hours or more, and there were very few individuals in these categories. So just I would like to put these findings into the context of dementia. We need to keep in mind that dementia is a multifactorial disease. It means that we have several risk factors that are likely to be involved in the development of dementia. And short sleep duration is likely one of these components, but we need to think as a global approach and not as isolation of each risk factor. So we need to consider all risk factors, including sleep duration, as well as lifestyle and cardiometabolic factors that are actually proposed as risk factor for dementia. Of course, I presented findings for sleep duration, but there are several other sleep characteristics and circadian rhythm features that needs to be explored in relation to dementia risk. And these factors are likely to be important both in primary prevention, as I said before, that we are measuring these components before the development of dementia, so before this 20 years preclinical period. But as mentioned just before in the previous presentation, it is likely that there is a bidirectional loop between sleep and circadian rhythm and dementia risk, which means that it is likely that secondary prevention targeting sleep or circadian rhythm might be also useful for slowing down the progression of dementia. So this is a very important topic that is investigated at the moment in dementia research. And that's all. Thank you.
Thank you so much for another very informative, interesting presentation. We do have time again for questions or comments. So anyone in the audience who has a question for Dr. Sabia, please. Yep.
May
Professor
I start?
Berger, please. Yeah, sure.
You also had the chance to compare subjective measurement sleep duration with more objective one. And you showed that they, in your final graph, that it's pretty similar. But how much overlap was there? I'm pretty sure you looked at or correlated at least the subjective reporting of hours of sleep with the objective one. And what was the result?
So indeed, we investigated this before. So we look at the concordance between the two, because one is in categories and the other one is continuous. So we found that when we look at real sleep duration, so the time slept with the accelerometer, the concordance was 0.4, which is moderate, but it's not bad. And when we look with the time window, so then it goes to 0.3, which means that people are more likely to report time slept rather than the time they spend in bed.
Okay, thank you.
We do have a question in the chat from Mutonikichu. I don't know if you would like to unmute yourself and come on and ask the question directly. If not, I'm very happy to pose the question to the panel on behalf of you. So there is an interest in if there are any recommendation with regards to sleep screening tools for the community, especially focusing on older adults that may be used to set up an initial sleep observation study. This may not only be a relevant question for Dr. Sabia, maybe that's something for Andras. Anyone who feels, anybody who wants to answer this question, please move ahead.
So maybe just to, I think that what we use here for research objectives was very simple question. As you could see, it was just sleep duration, very simple. There are other tools to assess insomnia that Andras has presented initially. The main question among older adults is to, for example, the Epworth for somnolence is not particularly adapted because people are less likely to drive or to go to the theater. So it's important to assess the full question and see whether they are adapted to the population or not.
Thank you very much. Any other question? All right, that's not the case. So I'm very happy to move on to our final speaker. But of course, last but certainly not least, that's clear. It's Dr. Céline Deleuze. She is a senior research fellow in medical gerontology from the Trinity College Dublin in Ireland. She's also a speech scientist and expert in interpersonal communication and social interaction, and usually does research on the intersection of clinical linguistics, phonetics, and neuropsychology, but she has also a broad interest in neighboring topics. So we will now hear her talking about sleep duration again, but also sleep problems and especially perceived stress and how they are associated with hippocampal subfield volumes in later lives. And these are findings from the Irish Longitudinal Study on aging. Dr. Deleuze, thanks for being here, and over to you.
Well, thank you for having me. I'm going to share my screen now. Okay. Okay, can you see this? Yes, perfect. Okay.
Yes.
Okay, so thank you for having me again. Today I was thinking about presenting one of the studies I carried out with some colleagues on the combined impact of sleep and stress on hippocampal subfield volumes. And first, I'll give a brief overview of the background. So we know that aging is associated with volume reduction of the hippocampus. However, there is marked heterogeneity in the degree to which the hippocampus is affected by age. The underlying causes and mechanisms are not totally well understood. But we know that there are other risk factors than age, such as genetic, environmental, and lifestyle factors, such as diet, education, and physical activities that have been independently associated with hippocampal reduction in older age. And in this study particularly, my colleague and I were interested in looking at stress and sleep and how together they may impact hippocampal volume. And the reason why we're interested in these factors is that first, we know that sleep disturbance and sleep dissatisfaction are common with advancing age. And indeed, sleep disturbance and short sleep have been associated with hippocampal atrophy in several sleep disorders, such as insomnia, sleep apnea, and narcolepsy, as well as among healthy older adults. And we know from animal studies that chronic sleep restriction and disruption have been associated with impaired neurogenesis, reduced cell proliferation, altered synaptic plasticity, and dendritic atrophy in the hippocampus. So the sleep appears like risk factor for hippocampal atrophy in older age. Now, stress also appears to be an important driver of reduced hippocampal volume. Indeed, some studies have shown that chronic stress and elevated glucocortical levels have been associated with lower hippocampal volume and dysfunction in animal studies. So, for example, in age rats, but also in patient population study in Cushing syndrome, post-traumatic stress disorders, and as well among healthy older adults. So stress signaling is initiated through the HPA axis, so through the secretion of the glucocorticoid hormone cortisol. The hippocampus is controlled the cortisol induced feedback inhibition of the HPA axis. And so because the hippocampus contains a high concentration of glucocorticoid receptors, then these make it particularly vulnerable to, for example, permanent neuronal and synaptic damage, which are caused by chronic stress exposure. Now, if we look at the literature, there is a bit of inconsistencies, however. So there are these associations. However, some studies also have reported no association between hippocampus volume and stress or sleep. And we thought that there may be two reasons for this. First, most studies have used what we can call a global hippocampal volumetric approach to assess this relationship. And this may actually obscure the fact that hippocampal subfields may be distinctively vulnerable to sleep deprivation or exposure to stress. Indeed, the hippocampus is not a homogeneous structure. It consists of multiple subfields, as we can see here in this graph, which have distinct histology, connectivity, and functional specialization. And we know, for example, from animal studies and a bit from human studies that, for example, the corner ammonis 1 and 3 and the data gyrus tend to be specifically vulnerable to sleep disturbance, as well as to higher levels of cortisol in the brain, or at least chronic stress. Another reason why we may see inconsistency in the literature is that most studies haven't really looked at the combined impact of sleep and stress on hippocampal subfield volumes. Yet we know there is biological and psychological evidence for interconnected relationship between the two. So it has been postulated that when dysregulated, each factor may contribute to pathophysiological dysfunction in each other. They may worsen pathophysiological changes over time, and this may lead to maladaptive responses. So to date, it's not very well known whether stress and sleep have independent, additive, direct, or mediating effects on the hippocampus. And for this specific study, we were interested in looking at whether self-reported sleep, perceived psychological stress, their changes over a 2-year period, and specifically their interaction were related to individual differences in total hippocampal volume, as well as hippocampal subfield volumes among community dwelling older adults age 50 and over. So to do so, we use the TILDA data set. So TILDA is a nationally representative study of individuals aged 50 and over who live in the Republic of Ireland. And for this specific study, we used data from individuals that had MRI data at wave 3 and also sleep and stress measures at wave 2 and wave 3. So we ended up with 400 individuals. Now, for sleep, self-reported sleep duration was assessed by asking participants how many hours of sleep they got on a weeknight, and that was then categorized into short, normal, and long sleep based on the National Sleep Foundation recommendation. And changes in sleep were split in 6 categories. With the indicating the original, the category of origin at wave 2 and how individuals may have changed categories at wave 3. So whether they remain stable or whether they changed. Self-reported sleep problems was assessed using 3 questions, and the responses to this question were combined to create a composite score, which gives us an idea of self-reported sleep problems. And the higher the score, the higher the sleep problems. And the change was used by subtracting wave 2 score from wave 3 scores. Now, perceived stress was assessed using the perceived stress scale 4. Which has 4 questions to assess global stress perception. And again, a composite score was created based on these answers to give us an estimate of perceived stress. At wave 3, a subset of TILDA participants underwent a multimodal MRI scan. And for this study, we specifically focused on the T1 scan, which has been processed using FreeSurfer. And we used the hippocampal subfield option to segment the hippocampus into 12 different subfields. So to assess the relationship between total hippocampal volume and sleep duration, sleep problem, perceived stress, sleep change, stress change, and the interaction of sleep and stress, we use ordinary least square regression. Excuse me. And to look at the association with hippocampal subfield volumes, we use linear mixed effect regression analysis. And we adjusted our model for a bunch of different factors, and I won't go into details, but I'm happy to discuss the statistical analysis later. So in terms of a quick overview of our sample characteristics, mean age was 68, 54% were female, 45% had a higher level of education. The majority, same with the previous study, fell into the normal category, and with small amount of individuals within the short and specifically the long sleep category, which limits a bit, the interpretation of our findings, I suppose. And sleep disturbance was mean 2 and perceived stress, so kind of a low enough sleep disturbance and perceived stress. So now if we looked at the characteristics of the participants who fell in the short sleep duration category, so they were more likely to be, older, live in urban areas, had more than one long-term disease, and had high levels of depressive symptoms, sleep problems, and perceived stress. Now, if we look at individuals who had long sleep, they tended to be older too. There was a tendency for them to be more on sleeping, cardiovascular, antidepressant medication, having more than one cardiovascular, long-term and chronic condition, but this was not significant. There was a trend, and again, it's due possibly to the sample, the amount of people in that group. Higher sleep problems were more prevalent among older adults, with a primary level of education, who had more than one long-term disease and chronic conditions, and who also had high levels of depressive symptoms and perceived stress. Higher perceived stress, finally, was more prevalent among younger individuals who had a primary level of education, who were taking sleeping and antidepressant medication, had high levels, had alcohol problems, and high levels of depressive symptoms. So now if we look at our cross-section analysis first regarding looking at association with total hippocampal volume and sleep and stress independently, we didn't find any association in our data set. However, when we looked at specifically the hippocampal subfield volumes, then we found, for example, that long sleep was associated with smaller hippocampal tail and smaller molecular volume here, as we can see on this graph. Also, we found that higher sleep problems tended to be associated with smaller volume of CA1, hippocampal tail, and molecular layer. And we didn't find, however, any association between hippocampal subfield volumes and perceived stress. Now, our follow-up analysis tended to confirm our cross-sectional analysis. So there was no association between total hippocampal volume and changes from wave 2 to wave 3 in sleep duration, sleep problems, or perceived stress. However, those who were in the long stable sleep, so remained the long sleep between wave 2 and wave 3, they had smaller hippocampal tail, molecular layer, presubicculum and subiculum volumes compared to the normal stable at wave 2 and wave 3. Those that increased their sleep problems from wave 2 to wave 3 had smaller volumes of CA1, hippocampal tail, and molecular layer, and increased stress level were just marginally associated with hippocampal tail volume. So something very similar to our cross-sectional association. Now, when we looked specifically, and that was kind of what we had really, were interested in specifically, is looking at the interaction between sleep and perceived stress and their relationship with hippocampal subfield volumes. Then we found that individuals who had short sleep, who also had reported high levels of stress, so those individuals here in green, they had smaller volume of CA1, hippocampal tail, molecular layer, and subiculum. Similarly, individuals who reported high level of sleep as well as sleep problems and high level of perceived stress, so those individuals in green here, they also had a smaller volume of CA1 and as well as molecular layer and subiculum, although these were kind of a marginal associations. So to conclude, we found that long sleep was characterized by lower volumes of molecular layer, hippocampal tail, and subiculum. We also found that higher sleep problems, as well as short sleep, but only when combined with higher stress levels, were associated with smaller volumes of CA1, molecular layer, and hippocampal tail. And we also found that higher sleep problems, when combined with higher stress levels, were associated with smaller volume of CA1. So these results tend to corroborate the animal literature and the few studies that have been carried out, so in human, and specifically show kind of suggest a specific vulnerability of the CA1 subfield to stress exposure. Now, in our study, we kind of, because we look at these subfields, we show additional association that have been reported in the literature with molecular layer, hippocampal tail, and subiculum. But when we looked again at the literature and look at populations with, for example, history of maltreatment and obstructive sleep apnea, we also these specific subfields were also found to be smaller and associated with stress and sleep disorders. Now, if we think at long sleep, and again, we can't do much of an interpretation of long sleep because again, there were, the sample size was small. But if we think about it, it seems almost counterintuitive that we found association between long sleep and hippocampal volume when one postulates that, neuronal damage may come from disrupted sleep or shortened sleep. So why is that long sleep may be associated with smaller hippocampal volume? Well, we know that long sleep has been associated with adverse health outcomes, accelerated cognitive decline, and also with a 70% increased risk of all-cause dementia. So there may be different explanations for that. The first one may be that individuals with long sleep just engage in more sedentary behavior, and we know that this may have an impact on brain aging. But we have kind of control for that with physical activity in our models. Something else also to consider would be that maybe long sleep is just reflective of poor global health. It's kind of a proxy of accelerated aging and giving us some idea that there will be some underlying dysregulation among several physiological systems, for example, the autonomic system or inflammation, etc. But in any case, long sleep seems to be a clinical relevant marker to identify individuals that may be at risk in the future of structural hippocampal subfield atrophy. Now, in our data, we also found up to 70% CA1 volume difference between individuals that combine high levels of sleep disturbance and stress and those that had low levels of sleep disturbance and stress. And this is important because if these are not combined, basically the difference between individuals are about 2 to 5%. So that jump up to 70%. And 70% is important because we know from the literature that these subfields have been found to be lower by 10 to 30% in subjective cognitive decline, mild cognitive impairment, and Alzheimer's disease. And the fact that we found larger structural differences when disrupted sleep and chronic stress co-occur, this seems to suggest that there is an active synergy between these two factors, and that therefore it may be important to assess and control sleep duration, quality, and stress together in neuropsychiatric research to identify maybe profiles of those individuals that may be at higher risk of structural atrophy and possibly accelerated cognitive decline and dementia risk. And just to finish here and to put a bit of context with the current pandemic context, we, at the very beginning of the lockdown in Ireland, we surveyed our participants about their mental health and changes in behaviors. And what we found is that 39% experienced an increase in sleep problems and 29% experienced sleep loss of at least 1 hour compared to previous the pandemic period. 29% reported high levels of stress, and almost a quarter of all the adults in Ireland reported clinically meaningful levels of depressive symptoms, and that compared to 8% in previous waves. We also found an increased stress and depression levels contributed to increased experience of sleep problems during the first COVID lockdown, and that specifically women, adults with a primary level education, and those who live alone were more likely to report this kind of high levels of stress and anxiety and depressive symptoms. So these findings are here and important, and they kind of support, I think, the importance of developing strategies to tackle the high levels of poor mental health in our population. And this is important to address potential risk in the future of accelerated hippocampal atrophy and possibly accelerated cognitive decline and risk of dementia. Thank you.
Brilliant. Thank you so much, Dr. Deleuze, for this, again, very interesting and informative presentation with such relevant findings. I think they have huge implications for risk reduction of cognitive decline in dementia. I would like to invite everyone in the audience. Do you have any questions for Dr. Deleuze? Yes, Herr Hermesdorf, please.
Yeah, thank you for this interesting presentation. The estimation of hippocampal subfield volumes requires a very high field strength. So did you employ a 7 Tesla MRI, or if not, did you employ specific quality checks?
Yes, so there is indeed, I mean, the difficulty with hippocampal subfield volume, as you were saying, is that the resolution of it. And what we use is the T1 images, and this was not for, and this is one of the, that's something that we put as a limitation of our work in our paper, is that we didn't have, so generally when we use FreeSurfer hippocampal subfield option, it is better to combine the T1 and T2 data. But the way we collected the data, so we couldn't, the T1 and the T2 data set could not be used together. So we only use the T1 scan, which is not perfect for the automatic segmentation of hippocampal volume. And specifically, one study has shown that this is specifically true for the molecular layer. However, what we've done as much as we could is all the data sets, so the 500 individuals we had at baseline, were manually checked for these to check the segmentation, and they seem to be okay within within the lines. But what we are saying here is that it's kind of there are other big data set like the UK Biobank that also use this kind of a framework and FreeSurfer pipeline for this. So what we would love is to bring this study a bit further and try to see whether we can replicate these results with a larger sample size, because we looked at automatic. Our idea at first was to look at possibly comparing a manual annotation and automatic annotation, but manual annotation is about 50 hours per individuals. So when you have those big data sets, it's not really doable. So we're hoping that by using other bigger data sets such as the UK Biobank, we could try to see whether the findings that we found can be replicated in other studies.
Okay, thank you.
Any other question? Professor Berger, yes, please.
This was a one-time MRI assessment, right? Or do you have follow-up MRI, or would you know, are these subfield volumes reversible once stress level or sleep problems solve? So over time, over longer periods of time, are those volumes might increase again if people have other living circumstances?
So we haven't ourselves follow-up analysis, and that's a bit of the limitation. That's what we're hoping to ask for, for more funding to get this kind of a, follow-up MRI data set with the same participants. It's difficult in the literature to see, to look at this kind of a MRI follow-up with also sleep and stress measures at the same time. And I'm not aware whether how much that would be reversible in what, period of time. But we know from the literature that lots of, factors have an impact and, show, reversible aspect on the hippocampus in general, rather than the hippocampus subfield volumes. And indeed, from our studies kind of limited in the sense that we cannot really look at, so we looked at the combined impact of stress and sleep, but we cannot really look at mediation effect or specifically, direct or indirect effects or, causality, because it could be also, and that's a question, that I have of interest, that, hippocampal, the hippocampal volume at origin may be, a factor that leads to, stress problems as well as, a sleep disturbance. But what we kind of looked at is whether, sleep disturbance and stress together may impact on the hippocampal volume. We cannot yet, untangle those relationships. But that would be a great work to be done in the future. Absolutely, yes.
Right. Thank you.
Any other thoughts or questions? Last chance. All right. Well, if not, then we are actually, well, thank you again, Dr. Laus. Then we're now actually coming to the conclusion of our today's symposium. And first of all, of course, I would really like to thank all the presenters during today's symposium. It was, to me personally, it was extremely interesting. I certainly learned a lot. I kind of have the feeling that sleep and stress are very hot candidates to be included in future frameworks for dementia prevention. Now is also the time, if anyone has any questions, any thoughts, anything to say or ask to anyone presenting today, please just unmute yourself, turn on your video. We love to see your faces, and we're happy that all of you participants that you made the decision to join us today, and we hope you have enjoyed the symposium just as much as we did. And I can see a raised hand, so I'm going to invite Marcella Rietschel to unmute yourself and let us know.
Yeah. Thank you very much. It was a very impressive session and I liked it very much. I was just wondering with many of the questions, if you have already thought of involving also genetic calculation in your ideas. As with the Whitehall study, you could look at the GWAS of sleep disturbances and see if there's an overlap with the GWAS of dementia. And I was just wondering if you have thought about it. As I'm involved in genetics from the Department of Genetic Epidemiology in Mannheim, this is my first thought. And so I was just wondering.
This is a very good question. Unfortunately, so far we have not looked at it because we are still building the dementia risk score, genetic dementia risk score. But this is planned to be done. Yes.
Thank you.
Okay, if there are not any further questions, then I would like to hand over to my wonderful co-host, Heike Minnerup. Thank you very much for organizing this together with me. For your final words or maybe closing remarks. We cannot.
Thank you very much for, yeah, I'm here. Thank you very much for all your presentations, and I'm very happy to have you here. And I will again encourage collaborations, and maybe several of you might discuss further, even not in this meeting, but we can, if you want, we can provide a forum for that, or you can contact each other personally. So whatever you want. I think there is a lot in common, and I was just Googling by the site and see, oh my God, Dr. Laus, they have the same MRI scanner as we do. So maybe we can compare findings. And so I think there's a lot of potential. So maybe you can answer to that, or whatever you think. For I'm not into sleep research myself, so it's up to you whether we can provide a forum, or whether you want to contact each other, or we provide an email list of all the participants. We can do that as well. Yeah, is that a good idea? Together with the study information of all presenters and participants that are interested. Yeah.
Yes,
okay.
We're very happy to follow up. And So it looks like Professor Berger has the final words of today. We're going to hand it over to you. Please close the session.
All right. May I just add one comment, because that's important. These mini symposiums such as that this morning is also always a source of networking, and we have seen many overlapping analyses and interesting results. And I would like everyone who's not so close to the German national cohort and to the cohorts presented here, but the German national cohort is similar to UK Biobank, one of those mega cohorts, and it is currently in its follow-up. So it's the third year of follow-up, 200,000, but it's a public domain source. So it will open for external researchers all over the world next year. So you might consider applying for data to analyze your results or your questions with data from the national cohort. And as you have heard, some of the presentations today coming from that, I didn't find any issue in one of your presentations that could not be somehow be addressed with data from the German national cohort. And listening to your presentations, I got about 1,200 additional ideas what could be done in combination and in cooperation, for instance, with the expert groups that are 20 in the German national cohorts, and one Marcella Rietschel and I myself coordinate is on neurologic and psychiatric diseases, where the issue of sleep-related analyses is highly welcome. There's a specific group on sleep disturbances where Jan Kantelhardt is a member. So you have a lot of contact persons right now already, if you're interested in future to use those data. And I just would like to welcome these applications. Use email, use whatever you have in contacting devices to network. And thanks again to Susanne and Heike for organizing it. I find it a very interesting and inspiring morning.
Thank you.
All right.
Yeah.
Perfect closing words. Again, thanks everyone. We've really enjoyed this. Enjoy the rest of your day. Stay safe and healthy during these turbulent times once again. And we hope we stay in touch one way or the other. We will be in touch for sure via email. So thanks again.
Thank you very much, Susanne.
Bye-bye.
Bye-bye.